Assalamu alaikum. Good morning, everyone. As we agreed, today's session, like exceptionally, would be one way. I will just try to discuss what I believe, because your time is very precious, and just the exam is 2-3 days later. So we are not opening the door for discussion. If you have specific question, yes, I'm more than happy to have them. And if you have specific weaknesses you want to discuss, I will be more than happy to discuss that. But after we do the 18 questions that you have asked about. Okay, so let's start with question 13. A final year medical student is attached to a firm. So you have medical student is attached to a firm. Why it is important to know that? Because now he is vulnerable. He is very junior. You need to promote for him, advocate for him, and he might do a mistake. The question might go for two scenarios. Either he has been he has been a victim. You need to really protect him. He is very junior. He's very weak. Or he is doing a mistake. You need to teach him because he's very junior to you. Now you are his boss. He is keen but often slow. Okay, he is keen, that's good, but slow. That means he is not obstructive or doing problems or something like that. He's just, this is his abilities. Often slow. Slow you down with basic questions. Is that important to know? Yes. Why? He is not a bad person. He's just, this is his capacity. But you have to understand, this might pose some delay or risk or underestimate your care to your patient. That's why they are giving this sentence. During busy ward round. Okay, now we are talking about ward round. Write this down. Whenever we are talking about ward round, we are talking about patient care until proven otherwise. You cannot stop the ward round and ask the consultant to go back to say sorry for the patient. You cannot do that. Why? Because ward round is a patient care. And patient care is superior to anything else. So when they are talking about ward round, you have to interpret that in your head. That's patient care. So he is somehow, let's say, delaying the patient care. So the consultant, which is the real boss, started to make a sarcastic comment, which is very catastrophic. He is this final year medical student. Why he is final year? Why they mentioned that? He is the next F1. He will be doctor in few months, few weeks maybe. So he is F1 to be. We need to train him very well and treat him very well. He's taking care of patients in a few months. So, but he's delaying the care. We need to address that. This is number one. Number two, I have a misbehaving consultant who's making fun, sarcastic comments on a very junior doctor because there is a power misbalance, okay, in front of the team, which is very catastrophic. So you have two big issues, delaying the ward round and making fun of colleague to be. Which one would you address first? The patient care is something potential. You have to understand that. We have learned that if it is immediate patient care, I will stop anything and just address the patient care. For example, if this student is struggling to put the cannula and the cannula midway, or someone is bleeding or something like that, you don't care about anything else. Patient care. But now patient care and quality of care is something potential. It didn't happen now. It might come to harm. So you have to understand. Please be careful. Potential patient care, ward round means patient care, but something potential, something will happen in the future. And someone being made fun of by consultant in front of everyone. And we cannot tolerate, we apply zero tolerance to sarcasm, to racism, to derogatory comments. We don't tolerate that at all. So how would you address this question? Pull the student aside, suggest they ask their question. This is good to address the delay in the care, but it's not addressing the immediate issue now, the outstanding issue. So it's addressing one of the issues. B, ask why it's good, because you pulled him aside, not in front of everyone. You are really trying to give him the chance to ask, but without interfering with the word round. So it's good for the second most important issue here. Ask the consultant to stop the comment undermining the consultant. I will start with this. Why? He is making the sarcasm. If they say it in the question, this is very important, write this down. If he made something in the past, that's it. Something in the past, you speak to him later on privately, but he is doing that now. You have to challenge him now, to stop him now. That's why B is a good one. A is good as well, but for the second most important issue. C, ignore the situation. You cannot ignore the situation. Make an effort to answer the question quickly. Now you are indirectly addressing the second most important, which is the delay. and somehow addressing, you are not addressing that he has been humiliated and bullied. You are not addressing that, but you are addressing the second most important issue, but indirectly. E, discuss with the student, they can best integrate their learning. So you are basically somehow blaming him. If you want him to improve, you are giving him advice. You are not giving him general comment and make him feel like he is guilty and he needs to improve and he is bad. It's not the way. So the answer will be B and A, the only correct answer. Each one of them addressing one of the major issues. So B addressing the most outstanding one, and A addressing the second most important one. Then you have E, C, D. Make life easy for yourself, which is the worst one. Definitely C. You are ignoring, you're doing nothing. So D or E, which is better? I would say D, indirectly addressing the issue, and E, discuss with him. So it's really tough. Uh, in the real exam, how can I make it very quick? D, make an effort to answer the question quickly yourself to keep the round moving and shield the student. So you are trying to address the two issues for future, not for what happened now, and you are doing extra effort. E, discuss with the student how they best integrate their learning without disrupting workflow. It's really tough. I might initially go for D because I'm making an effort, proactive. But wait, am I able to do that every time? No. Is it my job to answer the student question while the consultant is there? The answer is no. Am I there all the time for the student? The answer is no. So between D and E, don't go by emotion. Which is more reliable and more lasting solution? Initially, I would say D, but no. D, I'm not here all the time. This is not my job to answer this question. I'm just an F2. I cannot answer every single question. So that's why E, discuss with him. It might seem less sympathetic and less empathetic as well, but D is not reliable. You will something very temporary. That's why. So I wouldn't say this is a difficult question at all. It's just understanding the concept. The difficult bit would be between D and E. Any questions, or should we move for the next one? Next one. So you are working in a busy GP practice. During your clinic, a patient you saw 2 weeks ago for non-specific abdominal pain calls. So here, when they are giving you so much details, please understand. Please understand. This is situational question. You have to understand where are you now. It's really situation. Now you are in a busy GP clinic, and you are within your clinic, within your patient time clinic. You have to address the patient. Patient now, they have the right. This is their time. Why? Because you are during your clinic. Okay. So anything not related to patient and care, leave it later on. I'm making the question very easy for you. So why? You are not in a break. You are not even in this patient who is calling you via phone. You are not in his own time. It's not like a telephone consultation. You are doing your conventional clinic and he called. Okay, you can take calls, no problem. So patient calls, furious. The patient has been diagnosed with appendicitis at another hospital and had to have emergency surgery. That means you missed the diagnosis. Fair enough. They blame you for missing it. When he's doing that during the phone, via phone, is it his dedicated, designated time? No, it is the other patient time. So what should you do? A, defend your management, which is very bad. I can exclude the answer without knowing the stem because it's incorrectly built. We have acquired this skill. So B, apologize. Very good start. Apologize for the stress caused and explain that you look into their note and reflect. Very good. Very good. He wants you to say sorry. That's why he's calling you. And he wants you to learn from mistake. And he is not up to complain. They didn't mention that. So do the thing, say sorry, cut it short, focus on your current patients, and give him what he wants because you really did a mistake. So apologize and reflect. That's it. This will take just 5 seconds. Do it. Tell them you are sorry. This is again very close to B. They are unwell. But that complaint must go through the practice manager. He is not complaining. He is not telling you I'm complaining. So why to mention complaint? So C is good because half of it is good. You are saying sorry. And you are telling him, I have no time for you. Go through my practice manager. It is addressing the major concept, which is saying sorry. admitting your mistake, being humble, and really saving your time for current patient. You are not wasting time. And but less sensitive, someone who you did a mistake. So I would keep it still upper or middle, but it's good. D. Ask the details about the new diagnosis to understand what you have missed. What do you think about this? Now, he's not your patient, not your current patient. He has been taken care of. He deserves no medical care, no further medical care. He has been treated because surgery is a cure, it's not a treatment. For diabetes, you give metformin. This is not a cure. You will take it till you die. But surgery is a cure. No more appendicitis going on. That's it. You don't need any more care. So he's just calling for you to say, sorry, I did a mistake. Why would you ask him for something not even relevant? And it is not the issue. You have to understand that. The example is there. I thought about keeping this diagnosis about diabetes, but I thought, no, no, no. Diabetes, there is a follow up for the GP. Appendicitis, GP has nothing to do with. That's why this is very situational. When they give you specific example, you have to be focused on that. So appendicitis, surgical thing, they treated him totally. No more care warranted or needed. If you are doing D, you are wasting your own time, the other patient time, which is not even professional or legal. Say sorry, that's it, and go for treat your own patient. You cannot go further and ask him why and ask details. This is not your job now, and you are adding nothing. That's why D is very, very bad. D is against patient care for your current patient in the clinic. It's busy clinic. That's why he is not asking for care. And he does not need care. If he needs care, I will prioritize him, but he does not need care. That's why. E, advise them to make formal complaint. This is very bad. He's not asking for complaint. You have to acknowledge him. You have to keep a patient center of your attention, not to escalate. Okay? So, the best answer is B, then C. I have A, D, and E. They are all bad, to be honest. And this is the difficulty of the question. The worst is to not say sorry, which is the thing that you should do, and to ignore or compromise the care of your own patient, which is D, which is very tricky, to be honest. Oh, how come I'm asking him about symptoms and I need to be kind? No, no, no. It is situational exam. You have to understand that. You are wasting the time of the current patient. Why would you do that? So D is the worst because it's against patient care. You are not adding zero value. He does not need any care. It is appendicitis, has been cured. Why would you ask? You are adding nothing and you are losing your own patient time. It's already busy. So D is the last one. What about A and E? It's really tough again. Which is worse, to defend yourself or to escalate? Both of them are escalation. So A, escalation by defending yourself. E, escalation by telling him, go and complain. What do you think? He is not saying I'm complaining. He just needs a nice word from you because he's furious. Which is worse for a furious patient to say, I don't care about you. You are unhappy, just go complain. Have nothing to do with that. Or A. Actually, E is really tough. If you are in the exam and this is consuming your time, just put anything and go. You are scoring 18. But if you want to score 20, E basically including the downfall of A. A, the downfall is you are being insensitive. You are trying to defend yourself. In E, you are saying, if you don't like him, just complain. Which is including A. You are insensitive, not even telling him anything. At least in A, at least you are explaining something. You are explaining something. But in E, you are not explaining. You are not even bothered to explain. You don't care about him at all. So that's not. So the trick, prioritize your own patient, care, but give him the thing that he deserves and he wants, which is short apology, and cut it short and go ahead with your clinic. You can combine both. The deeper trick is you can stop, do like gateway task for seconds and carry on your patient safety and patient care. And we had so many examples like that. If the task is just taking seconds, do it, no problem. Like the catheter example, if you remember, just correct the catheter, throw the catheter in the bin or whatever, and carry on your way to attend the dementia patient. If you could remember that task. So if the task is taking seconds, no harm from doing it, especially if it's necessary, something important. Do it for seconds, but don't take more time. That's the difference between BC and D. D, you are taking more time. You're bringing this patient care into compromise, which is not nice. So This is 13, 14. What else do we have? 17. Yeah. Yes, yes. If you want to ask question, yes, please.
AD, AE, sorry.
Say that again? A is better. A is less harmful.
Yeah, okay, thank you.
Mm.
Sorry, Dr. Qusay.
Yes.
So,
Uh,
Yeah, tell me.
yeah,
Yeah.
so basically, can I say that, like, if I have an upset patient,
Mm.
like leaving him and excusing yourself and like this will be like a very bad thing because
Definitely.
I had this in two questions right now.
Definitely. Definitely.
Okay,
Definitely.
so this will
Agree.
be definitely lower.
That's
Okay,
why when you have a furious patient upset, this is like a hint for you just to address him.
okay, address him and not addressing him would be like in the lower, very lower. Okay.
No, no, there is no fixed role, Dr. Mihadi, because you have learned
Yeah,
situation. They might give you an option against patient safety. That would be even lower. They might give you another patient against autonomy. That's even lower. You have to understand why this is lower. Why? This is dismissing patient, but I cannot bring other patient into harm. I cannot do that.
mm, okay.
Yes, Dr. Samir?
yes, Dr. Qusay. So, if the patient was asking for a complaint, then option E will be before A, right?
Definitely, definitely.
Oh, okay. Thank you.
Option E would be number three, actually. Yeah. Yes, yes, before it. Yes, agree, 100%. Yes. So, 17. You are first to arrive to cardiac arrest. Cardiac arrest is the top medical emergency. There is nothing beyond that. When they bring this for a reason, for a patient on a ward, you have never led arrest before, never led an arrest. Okay, the patient is not breathing and has no pulse. I think this question is very clear. It's arrest and no bleeding and no pulse. This patient needs to be resuscitated. Straightforward. You should have no doubt about that. So, A, wait for the arrest team. You cannot wait. He's arrested. He will die. How can you wait? The only trick that you have never led is that a reason for you not to do resuscitation? No, because what is resuscitation? There is two different things. Deteriorating patient, which you will address him by A, B, C, D, E, and arrested patient, which you address him by CPR. You have to differentiate. If you are doing ALS, for example, someone who is having trauma or anything, you will start by A, B, C, D. But the point that you will appreciate he is arresting, as long as you are doing, you are carrying the ABCD approach, he is, for example, his heart start to stop or saturation start to drop, and he is arresting, you will stop the ABCD approach and you will go to the protocol of resuscitation, which is CPR. So that's why there is a difference between ABCD approach and an arrested patient. ABCD for deteriorating, initial assessment, but arrested patient, ABCD approach is not applicable. You have to start by resuscitating the heart. You have to start with the heart. Okay? So, yes, Dr. Faisal.
Dr. Kusai, if it had not mentioned that the patient is not breathing and has no pulse, then should we start from E, like from A, B, C, D, E?
No,
and
because he told you cardiac arrest. Cardiac arrest means no breathing and no pulse. They are the same.
that's the fact.
Yeah.
Okay.
Yeah.
Oh, thank you.
Cardiopulmonary. Yes, Doctor. Oh, so, A, wait, you cannot wait. He's dying. B, immediately begin chest compression. Yes. Why? Because this is CPR, not even ABCD. This is CPR. Even medical student, even lay people, they know how to do CPR. So that's why BLS is mandatory in NHS. You have to do it every year. You might have ATLS and ALS and whatever, everything else, but you need to do BLS every year, pediatric and adult. So B is the must you should start with. C, start shouting instruction to organize the word. Shouting is very good, asking for help, but look at this. To organize the staff into roles, this is not the this is not the first step. Why? He is already arrested. You have to start by chest compression, bring him to life, then shout. If it is ABCD, start by shouting, asking for help. But someone is arrested already, and they give you a fact, no pulse, no breathing, just chest compression. Then after that, you can shout, not the other way around. Focus on checking if he has the DNA. That's nonsense. Begin primary survey to confirm cardiac arrest is already confirmed. So B is the best answer. I agree. And A is the worst because you are doing anything. Now you have C, D, E. Shout, which is good. E is not appropriate because he is arrested. How would you confirm? No point from doing that. And D is very useless. Focus on D in ACPR. So which is worse, A or D? At least D, you are doing something. At least he might be DNA CPR, might be, but it is not valid. If you are not sure if he's DNA CPR, you have to go ahead with the resuscitation till you find out. But it's better than just waiting, doing nothing. So D is less harmful. I wouldn't say less harmful. It's at least you are doing something. So D is number 4 and A number 5. They are very bad. And B is the only correct answer. Now, this is situational question. Focus. Which is better? C, shout for help, or E? What do you think? Confirm. It's already confirmed. Why would you confirm something confirmed? Which is better, C or E? Someone should tell me, please. Yes, Dr. Mihan.
In my original answer, I said BCE, but in your answer, it was written BEC.
I need your answer. Forget about me. Why do you think it's C or E?
For me, is I want to shout for help to get people around.
That makes no sense. Look at this.
Because
You are not in the
cardiac
street.
arrest call. You're waiting for the
Someone already called for help and already put a call, and you came because of that call. So the call is already there. Why would you shout? Someone already shouted, not just like that. Do you know what does that mean? Call. Someone already shouted. Someone else put the call in the pager and contacted the resuscitation, and they announced that. And you came from different word for this. So you have to be you have to pay much attention to details. In C and E, you are repeating yourself. In C, you are shouting for something already being shouted, and you came because of that. If you are in coffee shop or a mall or whatever, I will start with C. Why? Because no one called for help. But now you are the first one to arrive because of the call. Someone already called. Why would you call again? If you call again, you are repeating yourself and do nothing else. C, shout again, and do nothing else. Basically, you are trying to escape. You are doing nothing else. E, not the appropriate way to assess confirmed cardiac arrest, but at least you are doing ABCD, which is clinical care. You are starting with airway, breathing. You are wasting time, but you will reach C. When you come to C, oh, he's really arrested. At least you will reach there after maybe 1 minute or so, at least. But in C, you are repeating yourself. It's already being called. That's very, very tricky. Again, if you are missing this, you are scoring 18, but we are aiming for 20. Yes, Dr. Sain.
Yes, thank you. Actually, I scored for this 16, but now after your discussion, so it looks like E is nothing because it's already confirmed.
Yeah.
So and I can't understand. According to your discussion, I can't understand why E is number 2. So because
E is not the appropriate way, but it's very valid. Why? Because in ABCD approach, you will start by checking the airway. Airway is patent. Then checking the breathing. When you reach B, you will listen to breathing. You'll say, oh, there is no breathing. When you go to C, oh, there is no pulse. Oh, he's arrested. So you are repeating yourself, but you are on the delayed way to reach that he's arrested. You don't need to confirm because it's already confirmed, but you will reach there. You will confirm he's arrested. Then ABCD approach itself includes some management. Airway, if not patent, you will open the airway. B, if no breathing, you will try to do chest tube and whatever. C, if not, you will start to compress him. So ABCD approach is not just assessment. It's assessment and treatment. But you are delaying. Why would you do something like repeat yourself and delay the treatment while it's already confirmed? So an ABCD approach is assessment plus treatment. That's why it's ABCD.
Yeah, okay, thank you. But to be honest, I can't imagine to start with B, then I go back to E. I can't imagine
It's
that.
not like that. It's not like that.
Yeah.
It's not a sequence.
Yeah.
Now you have just four options for someone who's already arrested. Just four options: to wait, or to shout again, or to look for the note, or to start ABCD approach. It's very basic common sense. You will go with ABC. Believe me, you will do that. You have
Hmm.
just four options. Just four options. What would you do? Would you check the note?
Of
He's
course,
arrested.
ABC.
Definitely, yeah.
Okay, thank you.
Okay. 18. A colleague confides in you that they are struggling with low mood and anxiety, low mood and anxiety due to exam stress. Okay, so now this is very classical example, isn't it? So we have someone who is depressed, low mood, and anxious because of the stress of the exam. Okay. It's find hard to concentrate at work. So it is not just a social life. We started with a social life, exam and whatever. Now this is even impactful in his work. They haven't told anyone else. So confined in you. This is very important word. It's private now. He's telling you I'm stressed for the exam, and this is starting to affect my concentration at work. So there is a potential patient safety. How would you address that? A, tell them to tough it out. So man up or be strong, as everyone finds exam stressful. This is very, very bad. B, encourage him or them to speak to their GP or occupational health. Why GP is correct? Because the issue initially is not with the work, with the exam, social life, his private life. So GP is the best. Occupational health is the alternative for the GP. Is the department in the hospital that will help doctors with things that affecting their work, conditions affecting their work. So it's like specified GP for you. So B is good. Promise to keep it secret, but do nothing else. Okay, to keep it secret, yes, very good. But it's really very good. The answer is no. Why? Because this is start to affect his work. If they say he is distressed and something, and he is working, his work has not been affected, I would go with C. Not the best option, of course, but I would go with C, like number 2 or 3. But here, no way. This is a potential patient safety. I cannot promise something like that. And he is depressed. So C is very bad. D, suggest to take some sick leave to recover. Again, sick leave, maybe not the best. And we have learned I can take sick leave if it has been prescribed by a professional, GP, occupational health. I'm not his doctor. I cannot give him plan of management. Sick leave is part of the management. I'm not his doctor. I cannot do that. But is sick leave a wrong thing? No. But I cannot suggest to myself. Why? Because I'm acting like his doctor. Sick leave could be the only option, but by the professional who should treat him. So I'm not against the sick leave. Sometimes you will find sick leave is the best answer. If someone, not sick leave, if someone is coming from, for example, grieving, someone died, there is a leave called compassionate leave, something like that in the NHS. So this would be the treatment. So in very specific occasions, leave would be the best one. If someone grieving, someone something like that. So this is meant to be, but not for a depressed person needs treatment. The treatment is by a professional who treats him. So D is not a good option. Inform the consultant. Why this is correct? Because he told you I cannot concentrate. He didn't mention please don't tell anyone, but he did not tell anyone. So it is your job. Why? He is depressed. The depressed person is not in his status. He cannot think properly. He cannot judge. So they made it very easy. They didn't tell you. He said, please don't tell anyone. That would be a challenge. He didn't say that, but he just confined in you. So you ask him, B. But if they said he's very depressed and he cannot even do anything, you will start with E. Believe me. Why? You cannot encourage someone who's very depressed. He will never go. For example, he's suicidal, he's killing himself, something like that. But this is very extreme. They will make it very clear. They will never keep you in the gray zone. They will give you another hint. He's not listening to the advice. He's very depressed, something like that. You start to take action. Why? Because we understand depression. Depression, you might kill yourself, let alone going to doctor. So it is not the case. You encourage him first. Then E, is real escalation, I understand, but why? Patient safety is first and foremost. No other option, safe. So B and E, the only correct answer. E with escalation, B without escalation. So then I have three bad options. Just dismiss his concern and ask him to toughen up. He is sick, ill. How can you say for someone who is sick, toughen up? This is against you being a human being, not just a doctor. So I would keep A as the last, and C is next to last, and unfortunately, D would be number 3, suggesting him sick leave. This is not the best course of action, definitely, but it's better than promising confidentiality for someone who's depressed who might harm patient. You cannot promise him. At least I'll send him home, at least. And A, you are even against that by being very insensitive, very, let's say, harmful on him. You might make the situation even worse. Not me, you will make the situation worse by asking him to toughen it up. So this is not a classical answer, but you have to know. A, C, and D are very bad. D is the least harmful. At least C, you are keeping him at work. He will pose a risk to the patient. D, you're sending him home. So D is better than C, definitely. Between C and A, which is better? To keep secret and do no more harm? Their harm is still there, or to cause harm yourself? And we have learned, believe me, I'm testing this. To let the harm to happen is better than actively causing harm. So A, actively causing harm. He's depressed and you are making that worse. Okay? So which question do we have now? Yes, ask question, please.
Yeah, sorry. So I think even if he asked me to not to tell,
Yes, agree. 100%.
so it will
agree.
change nothing, right?
Yes, in this scenario, yes. Why? Because he's already affecting his work has been affected, but they will make it difficult for you in your head. Oh, should I say? Should I not say? That's what I meant. But it definitely has no implication at all. 100%. I agree with you. Thank you for the suggestion. I 100% agree. Any question? No questions. Okay. So you are in the clinic. A patient offers you a large box of expensive chocolate. This is everyday example. The gift and the boundaries between you and the patient, and we have to understand that. Okay, the policy, make it easy. Policy is strictly about gift, but you can accept small gifts, like what? Like flower, card, things like that. You can never ever accept expensive gift, substantial amount, or you cannot accept cash. You cannot, even if it's £5, you cannot, because it will be interpreted like he's buying you. You cannot accept cash and expensive gift, and you cannot accept gift that is not for gratitude, for something else. How would I know? If they spend very short time with you and giving you gift, that makes no sense. If you provide very little care and they are giving you gift, it makes no sense. So it should be equivalent to the care you gave, and not substantial amount of not very expensive or money, and just for gratitude, to say thank you. That's it. Okay. So you politely refuse. So you did the right thing. That's very good. And we have learned a skill about that. The patient becomes upset and says, but I baked them myself. So this is a homemade and something very expensive. Okay. It's not a gift. It's just thank you. So the patient clearly cannot understand. If you don't take them, it will hurt my feeling after everything you have done. So the patient is very emotional, and it's expensive. This is a fact. And you did the right thing. This is the fact. And the policy is very strict. All facts. Suggest that the team share the chocolates in the staff room. So it is a gift for the department, not you personally. Again, you are going against the policy. You are explaining nothing. So you say in the beginning, you explain the policy. So you have done the right thing. You have done that. And he's still insisting. Because of that, he's insisting. Now you're accepting. You have no excuse. This is very unjustifiable. How come you know the policy? You explained it, and the patient was keen and adamant, and you just fall for that. You have no reason. The right thing is to say no. You said no, and he is still insisting. You have to find another way. But you cannot say, "Oh, he said no, I will take it." No, you have no excuse. Giving it for the team, maybe a little bit better than take it yourself if the team take care of him. If the team didn't take care of him, especially take care of yourself, because he is giving the gift for someone who is caring about, who cared about him. If you're sharing with the team who's even irrelevant, that means you are falling for this or giving someone gift who's not taking care of the patient. It's very tricky point. However, A is not upper tier, it's lower tier. You have to find a way to say no again. B, suggest a different way that they can show their thank, such as card or letter to your department, which would be greatly valued. Very good. So now you are finding another way. You are telling him you are this is not gift, this is thank you. There is another way to say thank you, but you should not start with this in normal scenario. Why? Because you should not suggest for the patient to give you a gift. Now you are not suggesting. He is insisting, and you are saying we might accept this, which is fine, which is fact. But if the patient is not giving anything, you cannot suggest, oh, can you give me a gift which is just card or thank you? You cannot say that. C, explore why patient feels so strongly to give a gift and what the gesture means on them. What do you think about this? Very good, isn't it? You should start with this. Now, the scenario is really very strange. He's insisting, you are explaining. You have to understand why. What's the concern? What maybe he's feeling this is like a must on him. He should just give a gift because, and he will be rude if he didn't. Maybe. Yes, Dr. Mihan.
I'm just asking because I remember in one of the classes you told us that if the patient is upset, then you're like asking him why, and like this, it will be like a very bad option. So why is this different here?
There is a big difference between asking why and exploring the reason. And this scenario is not about frustrated patient. Now you have frustrated patient, which is very important way of communication and engaging patient. That's very important. But on the other hand, you have a strict policy that is telling you this is legal and illegal. And we have learned the only thing that's more important than legal and illegal, I'm not talking about professional, about legal, is the immediate patient safety. Here, the patient is frustrated. We have to be very situational and upset, but because of not patient care, not something around his care, something around you, gift. So this is not a typical scenario. If he's frustrated against around something related to his care, his dignity, something like that, you have to address that. Because the reason for us to address upset patient, to keep our approach like patient-centered, to keep our approach like focusing with the patient, giving him work in partnership with the patient. That's why we addressing their frustration, isn't it? But now the frustration is irrational and around me. He is frustrated because I didn't get so nothing about his care, nothing. To keep the patient, to keep yourself as a patient-centered here is to say no. Why? Because if you accepted the gift, you will be biased. They say expensive gifts will definitely give you a bias. You will be biased because you accept the expensive gifts. That's why keeping patient a center of your attention here by saying no. So again, you have to address stressed, depressed, frustrated patient around their own care or their own issues, not around yourself. Around yourself, now you are being nice to him by saying no. This is the way. And again, the other way for you to address this question, you are exploring. Whenever there is a concern, now you have a concern. Why he's so keen? Because the patient is telling some explanation which makes no sense. He said, "This is not a gift. This is to say thank you," which is very weird, isn't it? It is a gift. So maybe he's misunderstanding. That's why he's saying this, not a gift. It's thank you. So that's one. So B and C upper tier. D, reiterate. We have learned if you are doing the same thing again, it is upper tier. I agree, but it would never be the best answer unless you have really very bad 5 answers. You will keep it upper. But again, rule of thumb, repeating yourself again would be upper tier, but number 2. So keep it as number 2 so far. B, C, D. A is bad. E, explain that homemade gifts, like he did, particularly problematic. Oh, this is very, very catastrophic. Why? The patient is telling you this is not a gift. This is to say thank you. And you are telling him specifically the thing that you have done, homemade, is very harmful. And of course you're lying. And because one of the very few things that you could accept, the homemade cake, homemade. You cannot accept it here because it's expensive. Homemade juice, for example, something very simple. You can accept that. This is one of the few exceptions. And you are lying, and you are blaming the patient, and you are making him or her feeling worse. She's trying to be nice. She misunderstood it, of course, or he, but you are saying no. This is even worse because homemade. You are blaming and you are lying. Why you are lying? Because one of the few things you could accept, homemade food. You could accept that because it's not expensive, substantial thing. So, and you're bringing safety and things like that. So it's very, very bad way of communication. E is the worst. A, because you're lying. A is accepting it and distributing with the team. So E and A are really worse. If this question came in the exam exactly like it is, I will accept if you keep A the worst. But for me, I would keep E as the worst because you are lying, unprofessional, and blaming the patient. But A accepting the gift, but A for me is less harmful than E because you are not accepting for yourself, number one, which is less harmful. Number two, you are already denying the gift, but he is or she is insisting. So this was your second or third attempt. So it might be a less harmful for me. So again, it's subjective, situational. If you kept E number 4 and A number 5, I might accept that. But for me, definitely E is number 5 because you are lying, blaming. You are lying. And in A, you should not accept the gift. Why? To act professionally. You cannot, on the other hand, lie. This is even less professional. But A, you're not accepting the gift for yourself. You tried that after you exhausted every other solution. That's why you accept it for the team. So for me, A is less harmful than E. Definitely C is the best answer because there is misconception here. How come gift is not a gift? It's just say thank you. So between B and D, D should be by default number 2. But hold on. Which is better? To suggest different way or to reiterate? I would say suggest different way because they really want to say thank you and count this not as a gift. And you need to be sensitive to them. So for me, I would say C, B or D, but B for me, A or E, which is very tough, but for me, A is better than E. But if this exam comes in the real exam, this scenario comes in the real exam, they might thought, okay, B is better, D is better than B because they follow that role of repeating the same thing in number 2. For me, I'll keep it upper, but less than C and B. Yes, Dr. Sami.
Yes, thank you. So actually, in your answer, it is C, D, delta, B, beta, A, then E. In your answer,
D is better than B.
in your answer, delta is better than beta. In your answer.
To repeat yourself.
No, sorry. In your answer, you posted the answers of the mock. So you put D before B.
I mean, to repeat yourself is number 2, to reiterate.
Okay, but the D now is the second one. D delta is the second one.
Again, I mean, you have done the right thing. And she's not accepting that. Okay? It's always keep it as a number 2 until proven otherwise. Otherwise means there is no better option at all. They are all bad. So you must keep it number 1. This happened just once. But usually in the real exam, they follow this rule. If you did the right thing and the patient didn't accept or something, repeating yourself would be still upper, but you keep it number 2. So
Okay,
repeating yourself, that's why B is number 2. So when you say the right thing the first time and the patient is not accepting, keep it upper, acceptable, but keep it number 2, not the best one. That's why B number 2. Now, exploring the reason, this is something new because you don't understand why she is saying that. This is number 1. And I hope that makes sense for you.
Okay, yeah, but sorry, yes, but your answer 21 says C, D, delta, beta, alpha, and finally echo. So this is your answer. So D is the second or the third one, delta. After all,
That should be the second because you're repeating yourself.
Yeah. Okay. And the last question. So I asked too many questions. So because the question says expensive
Yes.
chocolate, so we consider it as expensive because, to be honest,
It is a fact. It is a fact. You
for
cannot
the
argue
first
about that.
time,
This is a fact.
yeah,
They are telling you box of expensive chocolate. That's it.
for the first time, I felt that it's just a chocolate, even if the
Yeah, but they
question
are giving
says
you whenever Dr. Sumia, whenever they're giving you a fact, take it as a fact. You don't need to work your brain hard. It's a fact. That's
thank
it.
you, thank you.
I hope it's clear in this question why every single answer in its place. Okay, so is it 22 one of them? Yes. So you are waiting your discharge summary for the patient. You realize you forgot to document crucial negative finding in your admission clerking note 3 days ago. So this patient is staying for 3 days at hospital. So you clerked him initially when he first been admitted. You clerked him. You missed important negative. For example, abdominal pain, no Murphy sign, no something like that. So you missed important negative, which is fundamental to be in the discharge summary. You have to keep it in the clerking note and keep it in the discharge summary. You have to. However, you missed that. So this is in this question we have two issues: missing a documentation, and it's easy. We know how to address that. You have to add addendum or to write in the same paper but new date, something like that. And the discharge summary. The discharge summary should include the important negative as well. Okay. So how would you address that? A, add the finding to the original note, which is good. Original note, which is the clerking note, dating the timing for today. So if you're adding something, you have to keep the date for the date of the documentation. So you've seen him, for example, on Saturday, on Wednesday. You write that I've seen him on Wednesday, something like that. But the date and time should be for today. Why? Because date and time is related to the documentation, but the information is related to the visit, to the encounter. So the date and time related to the documentation. When did you document that? You have to. Okay. So A is good. B, add the finding to the original notes, but backdate it to the day of admission, which is what? Fabrication. You cannot do that. You are trying to be smart and okay, I didn't miss anything. I wrote it down on that day, which is lie. You cannot be that. And we have learned the patient record is a legal document. You cannot mess around with that. So B is very bad. C, omitted from discharge summary. So don't add this to discharge summary because you missed it. This is somehow honest, but you are keeping the discharge summary less reliable, and this is very unprofessional. Discharge summary should include the important information. Why? Because this will be seen by the GP and will be seen by the other doctors when he will be admitted next time. So you are really compromising the care in future, which is very harmful. Nothing to do with the probity and honesty, but with the patient care in future, which is very bad. Include the finding in discharge summary, which is initially very good, with a note that it was documented or said during the admission. Okay, that's very good. So you are writing something in the discharge summary, but you are being very clear. This information has not been elicited or demonstrated now, but in the early beginning. So I got this information from that time, but I'm documenting this in the discharge summary now, which is very good. E, write a separate addendum in the note. Oh, now we are not talking about the discharge summary. We have to document the note in the discharge summary. In the note, I'm writing addendum, new paper for today, by the today date, stating the omission from the original clerking. Okay. So in E, you are adding addendum, which is very professional, the most professional way to the note, and telling, oh, I missed that in the beginning, but this is important negative. I will add it to the patient record, which is very good. So the question is complicated. You have to document now. Which is better, D or E? Because they are the only correct answers. A, and B and C, they are incorrect. So which is better, D or E? What do you think? Yes. Yes, Professor.
Yes, I think E is better,
Why?
because you are adding to your clinical notes for the patient, because you don't want to mess that thing in your
Very good.
this
Very
edition.
good. Very good. Because we have said this summary is not a legal document. You can make it summarize, you can make it thoroughly, you can change a little bit. You cannot lie, but you can change a little bit. So if the patient wants you to keep something hidden, you might do that, but not in patient record. Patient record is the only documentation you keep everything. You cannot change. So if you have one chance to correct one thing, would be the note. E. E is the appropriate way to correct the note. D is the appropriate way to correct the discharge summary, but you are forgetting about the note. So E then D. A is you are less professionally correcting the note, less professionally. So that's why A is not top tier. You might argue A is better than D. At least I care about the note, but it's not the professional way. I should have added addendum. Yes, that makes sense. But in D, indirectly, you are indirectly touching something in the patient note by saying in the chart summary, this has been in the admission. So it's really tough, which is better, to less appropriately addressing the most important document or appropriately addressing the discharge summary, which is more important. It's really tough, but in my opinion, D is very appropriate and it might give a clue to the patient note. And a copy would be with the patient, a copy would be with the GP. So A for me is less professional than D. You might argue A at least addressing the note. I understand that, but for me, if I'm in the real exam, I will go for D. So E definitely number one. D or A. A is less professional, but for the most important document. D is very professional for the discharge summary. B and C are bad. So which is worse, B or C? What do you think? According to the concept we have learned, which is worse? Definitely C. Why? C is against patient care, against. B against honesty. You are being very dishonest, but C is against patient care. You cannot hide such an important information like that. Again, patient care is first and foremost. Okay. What question do we have? We have so many. Subhanallah. Okay, you are asked to see a patient on a ward with a self-discharge against medical advice. They call it DAMO or AMO. The nurse says they left the nurse says the patient left 10 minutes ago and wants you to document that. So what's going on? Now, one patient already left. You have been asked to come and see him, but when you come, the nurse told you the patient left 10 minutes ago and wants you to document that the patient left 10 minutes ago. How would you proceed? Okay. Document that the patient went against medical advice and take no further action. Okay, fair enough. That's standard action. B, try to call the patient on mobile phone to check they are safe and encourage them to return. Okay. Is B your job? If the patient went and he has capacity, this is his decision. But why B would be good or bad answer? What do you think? So if the patient has capacity, he is entitled to go. I cannot just keep him in the hospital. That's even hostage. That's even like I'm kidnapping her. So yes, Dr. Mihad.
So originally I was against this. I thought A would be the best, but now you were called to assess him. So before he goes and he does the self-discharge, you actually have to explain to him all the consequences and the consequences. So because you haven't explained anything, so it is your job to address that or try to at least. This
Very
is what I
Very
think.
good.
Yeah.
Very good. There is another point I will add. Very good. Does he has the capacity? Who knows? He has been like a patient, and you want to see him, so you are not sure. Maybe maybe the issue is in his brain, depression, whatever. You don't know. So he was a patient. This is a fact. Does he has a capacity or not? We don't know. He left. So this is your role. That means this discharge was a little bit premature. They need to explain to him. Some doctor needs to see him to say, yes, you are entitled, but this will happen. So there is some mistake happened. You need to compensate for that. I agree, 100%. So B is good. C, inform the consultant and ask them to call the patient. That's again very similar to B, but it is your job as F2. You can't do that without consultant. But again, going in the same direction, you are addressing the thing that the team missed. You cannot say, oh, this is the nurse problem. I don't care. No. So B and C are good. D, call the police. Oh my goodness. Why police? Vulnerable. How come you know? How did you know he's vulnerable? And why would you call the police? You are in hospital, you call security. So E, document the event and ensure follow-up letter. Letter is sent. Okay. So B and C, number 1 and 2, definitely. A, the standardized one, you are assuming that he has the capacity, which might not be the case. And in D, you are assuming that he is vulnerable. And we need the police, which might not be the case. How would you know he's vulnerable? So E and D going to assumptions. E, you are accepting that, but at least you are suggesting some follow-up. If you have been with 3 options, assuming he is capacitable or assuming he is vulnerable, you will go with the assumption, with the default, that he is capacitable, he has capacity. But you cannot go for that initially. Please try to understand that. We don't know if he has capacity or no. You have to act on that. But now you have 3 bad options. Either to leave him, or to bring him by force, or to arrange follow-up. Arrange follow-up is the best one. I'm not arguing about that, so E is the best, but I'm talking about A and D. You have just 2 options. Assuming he is vulnerable, he needs to be here by force, by police, or assuming he is capacitable. The default, common sense, is everyone has the capacity until proven otherwise. We are not sure. But if we have just 2 options, you will go with the default one, that everyone has capacity. So now, he might not having the capacity. That's why we are going with B and C. I agree. But you have been left with just 2 options. You have to assume either he has the capacity or not. Of course, you will assume he has the capacity. This is not an ideal, but you have no other options, either this or this. I hope it's clear. So 25. You are surgical F2. A medical consultant believes you. So you are surgery and surgical doctor, and the medical consultant believes you. If you can put a cannula in their patient because their own unions are busy, and you are also very busy, you are already busy. Okay, so what would you do? Refuse immediately as you are busy. This is a standardized again. You might go for that, but let's see. We might have another better options. Who knows? But I think refusing here would not be a bad option. B, agree to help. Again, you are busy, he's busy. As it's promote interdepartmental, yes, the intention is good, but I will keep A and B as a last options because you are busy as well. Suggest they can contact the phlebotomy team, which is good. Very good option because you are busy. Ask your registrar if you can prioritize this task from another team, which is very good. So far, C and D, they make some sense. E, say you will do it when you have finished your current jobs, which may be ours. Okay. Another sensible one. So I will go with either C or D or E, not A or B. C, suggest the phlebotomy. He is consultant and he knows about phlebotomy, but suggesting that, emphasizing in a nice way you are busy and giving alternative. And asking your registrar if you can prioritize, that's a good one. But what would they go for, C or D, or even E? E, saying that you will do it when you have finished your current job. Is that safe for your patient? The answer is yes. Huh? Sorry. Is that safe for your patient? Yes, because you are busy and makes sense for you. But is that safe for his patient that needs the cannula now? You don't know. The consultant is asking for a cannula. It might be an emergency. Did they mention that? No. Are you 100% sure that it is not an emergency or urgent cannula? No. The reason for the consultant to ask someone else to do a cannula while his team is busy, most likely because he is the consultant, he always represents the GMC in good medical practice. If that was another F2, one nurse, you will treat it differently, believe me. But this is consultant, and he's asking from different team. He knows you are surgical and they are medical. He knows that. That means there is hidden urgency. I cannot presume that, but I can presume the consultant is asking for something very important. That's why he's asking someone else. And I can presume the consultant juniors are all busy with more sick patient. That's why he's asking you. Why? Because the consultant will definitely do the right thing. If there is more important, less important job, he will ask his juniors to do him. So be very situational, believe me, medical consultant. So suggesting phlebotomy, that will help your problem, his problem. Asking your registrar, because the only counteraction here, the only counter concept here is that you are busy as well. But if this has been resolved, you will help him. I think all of us will help. If you are not busy, you will help, isn't it? So asking your registrar, he will tell you, oh, yeah, okay, you are busy. I might help you with this. Go do it. Or keep yourself, do what you will do. I will help him myself. So asking registrar is exactly addressing you are busy, addressing this bit. Because if this bit was not there, you will help him. I'm telling you, if you are not busy, you can help with generic doctor business because you are F2. You can do cannulas, you can do ABCD approach. You are a generic doctor. You are not specialized in surgery. You are just spending 4 months in surgery. So doing an cannula for someone who needs it is part of your job. After you address your own team, how would you address your own team? Being not busy yourself or asking your boss by prioritizing. So he will tell you, okay, go for this, I will take care, which is very nice. Why not? So for me, definitely D is the best one. C is number 2. And E is the last. Why? Because he's a consultant. You have to understand. If it is F2, nurse, E would be number 3 for me. But consultant means there is a hidden urgency. Why? Consultant knows what F1 and F2 can do. And he didn't ask his junior because they are busy. That means they are really busy with sick patient. And I need to prioritize this. So E would be me actively causing harm. If I'm telling him no, he will take the responsibility and he will do it. And we have learned letting the harm to happen is better, less harmful than actively causing the harm. In E, you are suggesting that you are actively causing the harm. I will do it, leave it for me, but I will delay it. And he is a consultant. And this might be an urgency. That's why E is the worst in this scenario. Why? Because juniors are busy, he didn't ask them, and he's a consultant. That means that this is a really important one. And you are causing active delay. And this is very, very tricky. And I believe, I would say roughly 80% of us will answer this question incorrectly. You have to be very situational. He is a consultant. You have to pay attention to that. And he's telling you the juniors are busy. That means they are busy with something more important than this. Otherwise, he's a consultant. He would manage. And he cannot do it himself. That's why I should treat this as sort of important or urgency. C is helping the problem. D is helping the problem. E is actively delaying the problem. You are suggesting to actively delay. He will not listen to you, but it's very bad. A and E, which is better? To go roughly help him or to refuse? Again, you are busy. And it is not registrar or F2. He is a consultant. So I thought it might be better to go. You might argue refuse is better. I really accept that, but you have to keep E as the last, I believe. Why? Leaving the harm to happen is way less harmful than actively causing the harm, which is E. So D, number 1, C, number 2, and E, number 5. And you can argue between A and B. It's really tough because you are busy yourself, and he is a consultant. It's really tough. So for me, I kept agree is better than refuse. Yes, Professor.
Yes, Dr. Kasai. So after this discussion, I think it now makes much sense. So initially, when I did the question, I actually kept E upper and D lower. And as a reflex, I thought that I should not escalate or go for help. I should do something on my own first before asking the registrar. So that's what I thought while I was.
It makes sense. What you are saying makes sense. But now you are busy, and this busy has been sorted somehow. You will help him definitely. He's a consultant.
Yeah.
How would you sort that out? By asking the registrar if you can prioritize, because you cannot prioritize over your own patient. You cannot do that. But C is another alternative. Now he's a consultant. and you are busy, which is better? But if they said you have sick patient, that's it. It's done. You cannot go. But it's busy and they are busy. And he didn't ask them, that means they are busy, more busy than doing a career. That means they are busy with something more important. So it's really tough. So I accept if you are saying, oh, I keep A better than B, B better than A, I accept that totally. For me, I would say A is better, maybe just 51%, and A is 49%. Just a little bit of difference. And I would not be 100% sure in the real exam how would they score, to be honest. But for me, I would go with A. With the sorry, with B. Sorry. Okay, any question? Yes, please.
Doctor, we just choose agree above refuse because he is consultant.
Yes,
Thank you.
because he's consultant and he said his juniors are all busy. That means they are busy with more sick patients. Otherwise, he will ask them. So it's combination of he's being consultant and his juniors are all busy with presumably more sick patient and more important jobs. Otherwise, he will ask them. Consultants represent the guideline. Any questions? Okay. You are on a ward round. Your consultant criticizes your management of a patient in front of the patient and the rest of the team. You feel the criticism is unfair. He definitely did something incorrect by criticizing you in front of everyone. How would you do? Defend your decision, your actions, and argue your point. Defending yourself itself is not a bad, but in front of everyone and arguing, this is not a constructive way. Why? Someone should tell me one word, will tell you A is very bad. One hint from the question, sorry. Yes, Dr. Miha?
It's in front of the patient.
I'm talking about the stem, not the options.
Yeah,
What word from the stem?
in the STEM, they say that you are right now situationally in front of the patient.
Very good.
So-
Word round. We are talking about word round. Word round represent patient safety. You cannot delay patient safety by arguing and doing that. You can do that later on, but not now. It is a word round. You have to keep the flow of the word round. Very good. So A is very bad. B, accept the criticism silently, which is not good. He is treating you very badly. To maintain professionalism in front of the patient. Okay. Now, you just accept it just for the sake of the patient, which is very good temporarily. Now you are in front of the patient. Definitely B is better than A. C, ask if you can discuss the feedback after the word round in private. This is even better than B. Why? Keeping the dignity of the patient, keeping the flow of the word round, and addressing the issue, which is less immediate and urgent than the word round. On time, in appropriate time. So C is better than B and better than A, definitely. Okay, D, make a joke of it. This is not the professional way. You cannot make a joke of it. To lighten the atmosphere and move on. So you are moving on. You are not stopping the word round, which is good. You are not delaying the care. Definitely, you are not delaying. The joke will take 5 seconds. And just joke is not very harmful, but is not very professional. Because you are joking about something you have been victim to. You are not joking about someone else. If you make a joke about someone else, that's very, very catastrophic. But it is yourself. So it is not helpful, not professional, but not very harmful. So I'll keep it as a middle or lower. It's not a professional way. Tell the consultant that you find their method, feedback, unprofessional. This is confrontation, will create argument, and you are stopping or delaying the care. Because this is start of argument, isn't it? So I would say B and C, the only correct answer. C definitely better than B. So C, B. Now I have A, D, and E. Which is worse? Defend yourself and argue, make a joke and make the round to flow, or tell the consultant you are not a professional. You're not a professional. I would say D is the best. It is very unprofessional joke, but it's less harmful. You are not stopping the care of the patient. So A and E, you are stopping the care. Which is worse? Defend yourself and argue, or tell the consultant you are not professional. What do you think? Someone should tell me which is worse, A or D? Not D, sorry. How come D? A or E? Sorry. Yes, Dr. Rasulullah.
In A, at least I defend myself, but in E, I tell in face of the consultant that he is unprofessional in front of the patient.
Very good, very good. It is more harmful toward the patient. Very good. What do you think, Dr. Samah?
I think A is worse.
Why?
It's defend my actions and ergo. And ergo is the point. This is mean discussion like argument. That
Yes.
is why I find it worse.
So it is worse in terms of the flow of the word round. Is that correct?
Yes.
Okay, very good. I will take Dr. Faisal and Sami and I will answer that. Very good, very good. Yes, Dr. Faisal, then Dr. Sami.
Yes, Dr. Kusai. So I think I actually put the E, I mean, above A, but now it makes sense because I think it's one-off incident and then it's not something, some pattern there or something repeated. So can I ask if it was something repeated, then in that case, should I keep E before A? Or
I agree with that 100%. And there is another reason to keep E better than A. A better than E now. But I agree. If it is repetitive, yes, you can say that. Very good. Yes, Dr. Sami.
Yes, Dr. Qusay. I think in terms of word round and the caring of the patient, I think E is better than A because E as you mentioned, assume that full stop and do nothing. So E, I just say unprofessional. So less time to discussion. I defend your actions. So it means more than, so take more time than E. So that's why I think A is less.
Very reasonable. Very reasonable. So you agree with Dr. Samah. I understand that. But I will
Yeah.
add one point and you will decide. Which is more catastrophic to the patient? To see a doctor defending his decision, which might happen, to be honest, or to hear that the consultant who is taking care of him is unprofessional, which is worse, catastrophic toward the patient feeling and trust.
It's a disaster for the patient.
So if you're arguing, just arguing your action, it's not professional because you are stopping the round, but it's something you can do. You should have argument for your decision and for action, and the patient would be more happy and more confident if you argue about your decision. I say that because of that. It makes more sense for him. But you'll delay the word round. Definitely, I agree. In E, you are telling the patient, listen to me, this consultant taking care of you is unprofessional. Oh my goodness, that's so scary. And we have learned something. Trusting the public safety in the profession is the worst thing. You cannot do it because how will you regain that again? He will never engage. He will say, okay, the junior doctor is being rude, telling his consultant he's unprofessional. Who's unprofessional here? Maybe him, maybe all of them. Who's taking care of me here? So it is really, it's very tiny details. So if you keep A and E, you flip them, you'll score 18. Fair enough in this question. Don't waste a lot of time just for 2 marks. Why? Because you will lose whole question at the end. You will miss 12 mark or 20 mark. But for your own sake, it is more catastrophic to curse, to belittle your colleague in front of the patient. That's the worst thing you could do. Write this down. Argument is delaying the flow, but cursing or belittling your colleagues in front of the patient, that is destroying the trust. You will not trust the team anymore. That's what.
No
and I
point.
think now, Dr. Samah and Dr. Samir, you agree with me, E is the worst.
100% I agree with you, and I scored in this 12. So it was the lowest one for me.
Okay. Now, if this question came in the exam, you score 20, inshallah. Yes, Professor?
Dr. Kusai, we had one example in one of the classes where we were on the ward round and then the consultant came and lashed something and then he said it's your fault. In that case, Minimox, yeah. So we can't accept the criticism in that case, right? Because
there's a difference between criticism and unprofessional lie. This consultant is lying around the patient care. That means this is risking compromising the patient care. He might do something else and he might deny it. Who will take the responsibility and how would we address that in future and correct our mistake? We will never be able to do that. That's why this is a potential patient care here. Here, there is no potential patient care. But in that scenario, he is doing mistake and patient came to her, or we have addressed that, and he's denying. That means we are not able to address the root cause and correct that in the future. We are not able to do that. That's why.
So he was lying in that case. Absolutely agree.
Okay, so what do we have now? We have now 29. Okay, so 29. You are F2 in busy medical ward. A staff nurse approaches you looking very distressed, very stressed. The nurse herself. She says, "I'm completely overwhelmed. We have discussed that. We have sort of staff, and I have not even had a break. I believe we discussed that. I cannot do all of my medication round on time. She looks almost in tears. Have we discussed that? Or I'm just...
Yes, we have done it. In the
Yes, we have done.
So the one who asked for that, are you happy or should we repeat it? I'm really happy to repeat that again. The one who put this question. Yes, Dr. Faisal.
Can you please repeat? Yeah, can you
No.
please repeat?
So again, you are F2 in busy medical ward. The nurse is collapsing, is bursting, is telling you so many things about herself. That means now your mindset needs to be changed. Now your patient is your nurse. She is the patient. She is distressed. She is collapsing. She is really overwhelmed. You need to take care of her. Why? Because of number one, her own well-being. Number two, for potential patient safety. If she is not able to do her job, she will put the patient at risk. Which is more immediate and more outstanding? The patient care or the colleague well-being? What do you think?
Colleague well-being here.
Definitely. Just give me a minute. So now it's a colleague well-being, and this is very immediate thing. So you need to address that first. So tell me, now I have why the option is not showing. Oh my goodness. So these are the options. So A, tell her to take few minutes in the staff room to compose herself, which is very important. Why? You are addressing her immediate well-being. You need to give her a break. Why? She is posing risk to the patient, number one. B, advise her to speak to the ward manager about staffing issue. This is good. Addressing the root cause of the problem. If we are addressing that, we are helping this, but this exam is situational. You have to understand, you have no other way. How come? If someone is collapsing, someone is very depressed, not in his state of mind, you cannot ask him to do this. This is for later on when they are very stable, they are in a better status, they can discuss something like that. Now you need to take care of her and to prioritize her own well-being. Talking about the patient, that something will not happen now. This will need few weeks and months to recruit and to change the policy, whatever. But you cannot ask her that now because she's collapsing now. Just imagine someone is crying and collapsing and telling her, go speak to someone. It is good, but not now. If they say, after she's stable, discuss with her the option, that would be nice. But not now, because we are talking about something now. This is not the best now. So B is good, but not now. C, whenever you have collapsed patient, collapsed colleague, collapsed senior, you cannot ask them to do like cognitive functions like this now, asking, discussing, not now, it's not for now. C, offer to help her with the medication, that's good. Under her supervision, that's good. Because you know about medication, but you are not a nurse. So if they're asking about something very advanced, like a nurse job, you might not be able to do that. But this is something with the medication you can do. You can help with that. D, suggest prioritize. Yes, you are helping her. You are prioritizing patient. That's very good. A, C, D. Yes, Dr. Faisal.
I was only confused with option C in this one because it says that you are on a busy medical ward. So how can I offer to help her with
Who is
medicine?
busy? You or the ward, or who is busy?
The ward is busy.
You cannot assume you are yourself. Unless they're telling you are very busy, you cannot help. That's something else. But the ward is busy, it might be the nurses, it might be something like that. So it doesn't mean that you are yourself as a busy. The ward is busy, you have so many patients, which is busy, fair enough, but you might be, as a doctor, well staffed, not like nurses. Might be. Yes, Dr. Faisal.
Thank you for this, Dr. Kusai. I think if you want to move on after this, I was just confused with this one, so I'm happy.
No.
Thank you very much. Thank you.
No. Yes, Dr. Mihal, sorry, I didn't see that, sorry.
Sorry, but in B, it's wrong because I asked her to speak to the ward manager. I should have asked her to speak to like the nurse in charge or
No, no,
something like
no. She can speak to the old manager, but not now while she is bursting in tears, and this is not the time for this.
Oh, okay.
Yeah.
Okay.
And you cannot ask someone, for example, colleague who is depressed, tell him, okay, you need to separate your feeling from patient. This is good advice, but not now while she's collapsing. She will never understand that. She will never be able to apply this. You need to take care of her first, stabilize her, then later on. That's why the exam is situational. Okay? So, you are the junior doctor in clinic. The consultant has stepped out and the patient revealed that I think we have discussed that. Being physically abused. Oh, so we discussed privately. So many questions about this. So basically, someone being abused. What should you do? You have first of all to assess. Does he has capacity or not? Capacity, number one. If he has no capacity, he is under your care. You do the best for him. You just refer to social service and escalate and tell your senior something like that. Safeguard him. Number one. Number two, has capacity. Now, if he has the capacity, an adult, I'm talking about adult, you need to ask him, what do you want to do? If he wants you to tell, you tell. If he wants you not to tell, you don't tell. Why? He has the autonomy. You cannot override his autonomy because there was an abuse. This is not enough excuse, unless exception. The abuse was severe to a point it was life-threatening or limb-threatening, something. Someone has been kicked till he had like internal bleeding, hemorrhagic bleeding, some intracerebral hemorrhage, for example, something like that. This is life-threatening. Why? Because this is classified as a murder attempt. Someone is trying to kill someone. You need to breach confidentiality. For whom? For the professionals. Not the newspaper, not the employer, no. For just safeguardian, social service, something like that. And caused by your senior. Now he's telling you not to tell anyone when he's adult and he has the capacity, I assume. Is it mentioned? No. What you should do, you should assess his capacity. But if there is no option to assess the capacity, I will assume he has the capacity. Why? Because it's safer to assume he has the capacity, safer in terms of default. Everyone has the capacity until proven otherwise. So A, respect is very premature. I will not go for A now. I will check other answers. Explain your duty to safeguard vulnerable adults. Okay, very good. Encourage the patient to report the abuse to the police themselves. Okay, very good. Inform the patient son. So now you're talking to the son. Where's the inform the son? You don't talk to the abuser at all because he will know, he will escape, and he will abuse more. You cannot do that, especially after confirming his abuser. Discuss the case anonymously with your consultant or a senior colleague. So why anonymously? Because you don't want to breach confidentiality yet. You don't have the power. You don't have the reason. You don't have the justification to breach confidentiality. He is capacitable adult. So you discuss anonymously without telling information. Just E means seeking advice without disclosing information, which is very nice. That's why anonymously. F, make a referral to social service. This is against his wish. Prescribe anxiolytic. How come anxiolytic? He's abused. G, sorry. H, advise the patient to leave home immediately. Is it your job? No. When would you do that? When the risk is like life-threatening, as we mentioned. So I have just A, B, C, and what? And A. I need to exclude one of them. So E, basically seeking advice without breaching confidentiality, which is nice. C, encouraging him to report the abuse to the police. He said, don't tell anyone. So this is against his wish, but encouraging, nice, just encouragement. He might say yes, he might say no. Explain your duty, which is very good. A, respect his confidentiality. So I will start by taking advice and explaining my duty. Is he vulnerable? We are not sure. Unless he is dementic and he is very old, but you are explaining your duty, which is very good. Now, either A or C. So the patient is telling you, please don't tell anyone, and you are not sure. Would you advise him to report that to the police? The answer would be definitely yes, if the risk was very high and it was a police case. The abuse might be physical abuse, like what? Like, for example, just pinching, for example, or physical abuse might be just minor pushing. You don't know. But if they mention it's very severe, like trying to kill, this is a police case. Now, going for police is very high escalation, and respecting his confidentiality and do nothing else might be correct if you explain and you are giving him alternative. So it's very tough, but definitely police is not correct unless they mention it was a very severe physical abuse. They made it vague. If they say, for example, a severe kicking, pushing from stairs, something like that, this is a police case. But you cannot assume it was severe without gathering more information. So A and D are both not ideal options, but B and E are ideal. If you are going to decide one option in this scenario, you will respect confidentiality, because this is a standardized thing. You need to respect confidentiality. But if they mention the abuse was severe enough, you will tell him to tell the police. Because you don't have that piece of information, it's just stick to the default. It's a very atypical scenario, to be honest. I don't think they will bring something like that in the exam. Yes, Dr. Samir.
General question and specific for this.
Yeah,
Also.
please.
So when the patient tells me, please don't tell anyone.
Yeah.
So this piece of information, including my colleague in my workplace or my
Very, very good question. Don't tell anyone means anyone. If they said, please don't escalate or something like that, it means don't tell the police, don't tell something like that. So the only exception is the doctors that are taking care of the patient, because they are just like you, because they can in any moment just come inside and listen to him. However, if the patient mentioned anyone, you cannot tell anyone. You can seek advice anonymously because you are not breaching confidentiality. I'm talking about patient who has the capacity and has the autonomy, and the risk is not life-threatening. Now you don't want to tell anyone.
Okay, sorry, but you just mentioned the healthcare professional who are taking care of the patient. So here it says anonymously with your consultant.
If he said don't escalate, but if he say anyone, that means anyone, even the healthcare professional.
Even if in the same team.
Yeah, because he said anyone, don't tell anyone. He is capacitable. He understands what he's saying. If he's saying don't escalate, that might not include your team. But if he said don't tell anyone, that means anyone other than you.
Okay, sorry. So if option D says discuss this case with your consultant, it will be wrong, right?
Yeah.
If says discuss this patient with your consultant.
Yes. Because you believe he has the capacity and you cannot go against that. You have no reason. Yeah. There is no enough risk, severe risk, to breach the confidentiality. If there was, you will do safely. But you have no risk. Any question? Yes, Dr. Faisal.
Dr. Kusai, in which situations can we make a referral to adult social services, like in this context?
Is if the injuries was severe enough, you will encourage him and you will do it yourself. And if he was a minor, less than 18, and if the patient has no capacity.
Okay, thank you.
Now, a colleague asks you to a body sign. Body sign means like a friendly sign for a controlled drug. So controlled drug, you need so controlled drug means in some trust you need two healthcare professional doctors to sign, or we use this milligrams, whatever, and this left, something like that, because it's controlled. He's asking you to do that friendly without you witnessing that. He discarded the rest of it or whatever. So they say they are in rush to get to another emergency. So he is asking you to do that, let's say, in an unprofessional way. What would you do? Refuse to sign, and this is unprofessional. irresponsible to the and irresponsible to the policy? Yes. Professional irresponsible to the policy. Okay. That's good. You should refuse. Why? Because you haven't witnessed that. B, sign it to help him. You cannot do that. Offer to witness the waste of the remaining drug if they drawn up too much. So you are telling him, okay, let me see the rest of it, which makes no sense as well. Suggest they find the nurse who they were originally with to witness it. Very good. So you are saying, no, I'm not doing that. Professional. Giving him another alternative, which is appropriate alternative, which is very good. Then report the colleague to pharmacy department. Reporting him, you don't need to do that unless he's insisting, because you are still talking to him. If he's convinced, that's it. If he's still insisting and I say, no, I'll go illegal, you might do that. And if you're reporting him to your supervisor or his supervisor. It's better than reporting him to the pharmacy. Okay. Quickly go with them to the patient beside to verify the dose before signing. So F is a good one if you can do it. What does that mean? So if you can quickly go to the patient and see the medication, if the medication is there and you can witness that physically, why not? So you might say, okay, in A I said no, and in F I'm going with him. One of them is incorrect. I cannot go. Again, we have learned that skill. You might address one question by two different approaches. If they are both correct, they are both correct. One of the most famous examples, it was in foundation paper. One of your colleagues, I think, or it was in Oxford, one of your colleagues has written something in the Facebook or something about his visit and your consultant, and you have not been there. So one of the options is to do nothing. You have nothing to do with that. One of the options, and the other two options, you have to choose three. To talk to him or her and signpost her to the pulse. So you might say, okay, how come I say do nothing and talk to her? If they are correct, they are correct. That means you have two ways or two approaches to address the question. Okay, that might create so much confusion in the exam. When should I apply that? When should I say, no, they are contradictory to each other? I cannot take both of them. The answer is you have to know the other options. If the other options are ethically or professionally incorrect, that means this question could be solved twice. Either you say no, ask the nurse, which they go together, or you go with him if that's possible, which is good. Why not? So you might have three answers, two forming story and one forming different story. And both stories are helping the issue. So why not? Why I'm saying that? Because B can never be correct, and E can never be correct now, and G tell them to document it themselves as an exception is not correct, because there was no exception. If there was an exception, some patient is dying, something really arresting, that's an exception. But it was not the case. You are lying, basically. H, ask registrar if it's acceptable to back sign for control. You know it is against the policy. How would you ask a registrar? It doesn't make any sense. So they are both correct. Yes, Dr. Mihad and Faisal.
Sir, in the mock, there was a question where we recorded like necessary deviation. So how is this different from G? Because here he's also saying that I am running to get to another emergency.
That's a good question. In that mini mock, the operation was aortic operation. So we are on theater and we needed that clamp or whatever intraoperatively. The aorta has been operated on. This is a real-time emergency. We're talking about laparotomy and open aorta. Here he's saying, okay, I need someone to sign it with me because I am in rush to get into another emergency. Is that enough excuse to not ask the nurse she has been with you to sign? No. You are coming to me now. How come you say something like that? So the emergency here is not real, and the emergency that might excuse you, it should be per se immediate patient safety. If he has an emergency, for example, to social emergency or medical emergency but not an immediate patient safety, you are not accepting that. So they cannot make it vague. They should keep it very precise that immediate patient safety, so you can use your judgment and say, as a clinician, I really judge this is an immediate patient safety. For example, I've needed to attend arresting patient. Now this is an excuse, but not a vague example. You cannot justify another emergency. What kind of emergency? You need to use your justification. Yes, Dr. Samir, thank you, Professor.
Thank you. So option D suggest to go to the patient. No, not D, because I can't see very well. The option F, yeah, quickly go with them to the patient bedside to verify the dose. So sorry, everything is written in computer. So how it helps if I go? So how can I check if the dose is already given inside the patient? So how can I verify the dose?
No, here they are talking about controlled medication. It could be like tablets, which is not the job of the doctors. It might be like injection. So he dispensed some controlled medication, and if you went there and you have seen, for example, the dose, either the package or either for some reason you have been able to clarify, that's fine. If you couldn't, that's why you say no. That's why A is correct.
Okay.
So if you could verify the dose by somehow, but it is a fact, you are verifying, you are sure that it was the dose, because some controlled medication, they are injectable, and the syringe and the tag would be there and everything would be there. So, and asking the patient himself, it would be like a good way to verify.
Okay, thank you.
Yes, Dr. Faisal.
The last sentence in this time, Dr. Gusai, they say they are in a rush to get to another emergency. Shouldn't we consider it as a fact to go for option G? So I got G.
It is fact. It is fact. But are you accepting any emergency as an exception to go against the policies? The answer is no. We are just accepting the immediate patient safety emergencies. Emergencies are so many. They are different, but not every single emergency is enough justification and exception for us. The only emergency we accept is immediate patient safety. So if they mention they went to because they are in rush to for example next door patient was arresting, for example, or next door patient has been called to next door patient who was very high or very low blood pressure, I might accept that. But generally, vaguely, is not acceptable.
Thank you.
It should be immediate patient safety. Okay, so what question are we up to now? 38. Is that correct? 38. 38. So you are F2 on the ward. A newly qualified staff nurse asks you to show them how to perform complex dressing change. That it's beyond their current competence. So they are not being lazy. They are not delegating their task, but they are new. From the question, you can tell they are new. So how would you address that? They are anxious. This is, again, new piece of information, and the patient is waiting. So it's really coping under pressure because they are new. They want to do that now, and the patient is waiting. This is the most important bit of information. So tell them it is not a doctor job to train nurses, and they should ask their supervisor. Is that correct? Yes. Is that your job to train nurses complex dressing? It's not your job. Should they ask their supervisor? Yes. So why A is not a good option? Yes, Dr. Mihad, then Faisal.
Because the patient is waiting.
Okay, but that might not make A is wrong. Patient is waiting, they need to ask their supervisor. What do you think, Dr. Faisal?
I think the GMC were advised to teach the juniors. So it's like the educational opportunity for the nurse. So maybe I'm a senior person to the nurse, and then I can show her and teach her. So I can't, I mean, tell her to that I can't teach you, or I can't train you. So that maybe that's
The answer here is because of D. Look at D. A, tell him this is not my job, go for your senior. D, you advise them to find more senior nurse supervisor. Look at the difference. If you have two options and they are finally doing the same job, addressing the same point, they can never both be correct, and they are rarely can be both incorrect. So one of them will be correct. So A and D, they are the same thing, but A with no communication skills, very bad communication. So the answer is one of the objective here, inter-colleague relationship. Even if you are not able to help, you are able to signpost in a nice way. You cannot say, this is not my job, find someone else. You could advise them. So teach them something. Now, D, you teach them how to seek for help. You cannot, for example, teach them how to dress, but you can teach them how to seek for help. Why not? So A and D, they are doing the same thing, but in nicer, professional way. If someone needs help, you got to support your colleague. They are new, they need support. So D is very supportive, basically doing what you are saying in A, but in nicer way, without the fact that it's not my job. You don't need to say that. Even it's not your job, be nice. This is not an important piece of information. Support them, advise them, guide them. It's very nice. They are new. You needed the guidance when you were junior. They will need the guidance. So D is replacing A. You cannot go for both. And if you are going for D, you are automatically canceling A. So this question is built to assess your skill about 3 best of 5. 3 best of 5. One of the skill is if you have two similar options, you will choose one. And the nicer one in communication, it will be the good answer. I've been keep repeating that all the time. So D is better than A. So D is automatically incorrect. B, offer to do the procedure for them this time while they watch. So is that correct? I might say, if I know, presuming that I know the procedure. Okay, I will keep it. It's really helping the patient. It might be a good option. C, suggest you do the procedure together as a learning opportunity. Hold on. I've learned the skill. I've just learned the skill. And I have two options. They are doing the same thing. One of them is correct. So B and C, the same thing. B, I'm doing it. C, I'm doing it, but with them, so they learn. So they can never both be correct, and they can never be both incorrect. One of them is correct. I'll go C, definitely. This question is really tough, but just knowing this skill is saving your back. Now, A and D, they are pretty much similar. I go with D. B and C, they are pretty much similar. I would go C. Very rarely, they might be both incorrect, but that's very rare. You will know that at time. But now B and C, they look similar. They look nice. C is nicer. I'm doing the job because the patient is waiting, but I'm teaching her, giving her learning opportunity. So why not? So B and C, I will go with C. A and D, I would go with D. Okay. E, explain that you are too busy. Are you very busy? No. So why would you lie? Find someone else. Again, D, similar to A and B. D is similar to A and E. So D is better than A and E. F, report the nurse. How can you report someone who's asking for help? She knows her remit and she is safe, and you cannot report someone who's safe. No. If she did that without enough training and she brought patient to harm, you might report her, but not now. She is being very safe. Look up the trust policy for the procedure with them. Again, is that my job? No. Should I do that? No. Could I do that? Yes. Why? You are not busy. You have nothing to do now. How did I know that? From the STEM. They didn't mention anything. If they mention you are busy, you have sick patient, you cannot do that. But now they are stressed and the patient is there. So what is the harm of G? I cannot go for B because there is a C. I cannot go for E and A and E because there is D. So that means I need third answer. It might be G. Why not? I'm not 100% sure yet. Encourage her or them to tell the patient that they are not yet trained to do so. That's very, very bad. If you are not trained, you will find someone else to take care of the patient. If you are not trained, this is the opportunity for you to learn. Why not? So again, if they mention that in the STEM, you are not able to help, or you have not done that before, or you are not confident, the options will be totally different. But now they didn't mention that. And looking for the policy that might help you and help her, and asking the senior is providing enough safe escalation and signposting. And if you are able to do that with her, that would be better than doing that yourself, and she's not even learning anything. So the patient is waiting. This needs to be done as soon as possible. Delay is not a preferable option here. But again, if you have two options, they are similar, you go for the better one and you cancel one of them. And most likely one of them would be correct. This is all that question about. Okay. 38 now, we have 39. Any questions around this question, please? Any queries around this question? Okay, let's go for the other one. Okay. You are asked to see a patient on the ward who is extremely anxious about having MRI scan later today. They are claustrophobic. Claustrophobia means, I believe all of you know it, you have phobia from the closed narrow spaces. What would you do? A, cancel the MRI. You cannot do that. And say the patient is refused. Patient refused. This is even a lie. You cannot cancel yourself. This plan has been this MRI has been planned by consultant. You cannot cancel consultant plan. Prescribe one of those short-acting benzodiazepine. I will leave that for now. This is not my first step. Inform the radiology department about the patient anxiety, which is very good because they are the radiographer and the MRI technician. They are the one who is doing that. They need to know, which is very good. Is that like breach confidentiality? No. Why? Because the patient, they are taking care of the patient. They need to know. If you are not telling them, you are doing less favor to the patient. Again, it's just like patient having allergy or anaphylactic shock. You cannot hide that. It's your job to tell them. Why? Because they are taking care of the patient now. They are in charge of the patient. They need to know. Who else will tell them? The doctor. So she is appropriate. And it is patient safety, yes, because if he's claustrophobic and he is going through that tube, he might move. The MRI would be just a waste. So this is a patient care and patient safety. He needs to stay still in the MRI. So D, suggest the patient listen to music. Is that going to help claustrophobia? No. How do you know? You are an F2, you are not a psychiatrist. Claustrophobia needs to be addressed by psychiatrists, not music. Explain the importance of the scan and encourage them to just try their best. No, nothing called just try. This is, in fact, he is claustrophobic. He is not faking symptoms. Discuss the alternative imaging CT scan with the requesting team. Are you entitled to do that? Is that part of your job? Can you do that? Please, someone should tell me. Can you do that?
Yes, you are on discussing.
Very good. What do you think, Dr. Faisal? Very good, Kerman.
Yes, we can discuss. We are not changing the plan, or
Yes.
we are just suggesting, so we can.
Very good. Just discussing. Very good. Yes, Dr. Samir.
Yes, the same thing. It's just discussion.
Yeah, okay. So changing the plan is not your job, but discussing, why not? Tell the patient nothing you can do. That's very insensitive. How can you do that? H, ask the radiographer if they can talk to the patient through the process. This is a good option, but again, addressing no point. You cannot solve something, not even a question, not even a problem. He is not querying about the MRI and the procedure itself. He has claustrophobia. How taking the patient through the MRI would help him? That is not going to help him. So if he is querying the MRI, if he is telling you what is it about, I'm not sure about it, yes, it might make sense. But now he has having claustrophobia means he has the problem about the space in the MRI. So telling him about the MRI would do that. This is not going to help. Will emphasize the fact that he will go through a very narrow tube. So I might keep it number 5 or 4, but it's not really helping. So again, suggesting, that's good, but it might not help the problem. They might need an MRI. They might already exhausted the CT scan. For example, brain. They've done the CT scan and it wasn't conclusive. So still the MRI need is there for D, but it's worth it to try. And inform the radiology department, that's good, but it might not help. So are we going to do it or not? Still. So the only actual solution might be the benzodiazepine. Why? He will be drowsy a little bit. He might be able to stay still, and we might do it. But you might say, is it safe? One off, short acting, yes, safe. We do that all the time for tranquilization or whatever. But now, if someone asked me from different department to prescribe benzodiazepine to my patient, I will not do that. Why? Because I don't know the history. I don't know if he's allergic or not, and he is not my patient. Now we're talking about about my patient. Someone asked me to see him, and he's anxious. So benzodiazepine is a help for anxiety. Yes, we know that medically. Short term, yes. So he's my patient. I'm seeing him. Prescribing benzodiazepine is not the first line. I would never go for that, but I kept the options in a way there is no other alternative or other good option. Talking to the patient, patient, asking the radiologist if they can talk to the patient to the process, that is not going to help. And this is inappropriate delegation. If someone should talk to the patient through the MRI, should be me. I'm his doctor. Yes, Dr. Faisal.
So option A, I thought that talking through the process might relieve the anxiety, and then although it's not, it wouldn't help in terms of any. I'm not too sure, but
why he's anxious, Dr. Faisal?
Sorry.
Why he's anxious?
Yeah, because of the MRI scan, and then
he's anxious because he has claustrophobia, not because he doesn't know about the MRI or this is the first time. He's anxious for a reason, because claustrophobia. So talking him through the procedure is not going to touch the claustrophobia at all. Actually, it might increase the claustrophobia. Claustrophobia could be treated by medication or by cognitive behavioral therapy, which is you understand what's cognitive behavior. You expose the patient to stressor, then relieve him, something like that. So it's a constructive way, like 10 sessions, not just talking to him through the process. Yes, Dr. Sami.
Yes, for option F, discuss alternative imaging, example CT. So CT is exactly the same MRI. So we go inside the tube and the cloud.
Shorter time, very, very short. CT scan could be done in 10 minutes, but MRI is 1 hour. That's why.
So it's a matter of time only.
Claustrophobia means you are really scared in closed spaces, and giving benzodiazepine might wean off after half an hour or something like that, 1 hour. So having shorter time is advantage. Shorter time scan would be an advantage.
Although both CT and MRI are confined space.
Yes,
So,
definitely.
okay, thank you.
But CT scan, first of all, is just an example here. It's not you are telling him go for CT scan. So it's just an example. Number one. Number two, the fact that you discuss, you will come up with a plan. They might tell you, okay, CT scan is just as harmful as MRI for claustrophobia. There is no point. You have learned a new thing. So that does not make option F as wrong, because you are just discussing the point that you are raising concern and looking for answers. They might tell you exactly CT scan is just as harmful as MRI. There is no point. Then you will say, okay, that's even emphasizing the answer of giving benzodiazepine. You will be more convinced, because every other alternative has been exhausted. So it's very useful. Okay. So what do we have now? 43. Okay. You are in a clinic. Your consultant has a teaching style that involves frequently quizzing you in front of patients. Today, they ask you a complex question about rare drug side effect that you don't know the answer to, which might be a real life question. The patient is watching. What would you do? So again, if it's all round, you don't aim to stop the all round, but you cannot accept humiliating or something like that. I'm talking generally now, not this question. Okay. So bluff your way through the answer. That means going in circles to avoid looking incompetent in front of the patient. This is not a professional way. If you know something for your own sake and for your own humbleness and for your own learning, you are just a junior doctor, you have to learn to say, I don't know. Even the consultant here, they say, I don't know, and they don't know. You cannot bluff around. You cannot do that. But you can say, I don't know, which the patient would appreciate because there is a consultant anyway. And knowing your limit, that means you are able to ask and seek for help when it's needed. So don't think, oh, if I said I don't know, that means no, I'm looking incompetent. This is for your own practice and understanding. You should be clear about that. So admit honestly that you don't know, which is against A, but assure them you will find out. You admitting, yes, this is the answer for the question, and assure them you'll find out is a fact, yes, because as a junior doctor, you have to learn. If you didn't know something, you have to learn about it. So it's very good. So B is against A. C suggests that the consultant probably knows the answer and ask them to explain. So if someone asks me a question, can I ask him back? What do you think? Yes, Dr. Faisal.
I don't think so that it would be appropriate to ask on I ask back on the same platform. So maybe later on.
Hmm.
So I don't think so.
Okay, so what do we think, all of us? Do we agree about that? Yes, Dr. Rasulullah.
I think it is a clever way to give him back the question and tell him that I'm sure you know that you can explain it to me.
So now we have two different views against each other. The answer would be according to the phrasing. Look at the phrasing. Suggest, which is very nice. You are not asking him back. If they say ask the consultant back, that would be very rude. If they say reply back to him like you are embarrassing him or confronting him, that's against the flow of the word round. Now you are suggesting. He might say, not now, we'll discuss later, because you are just suggesting. And it is your right to suggest, but it is not your right, maybe, to confront, to ask back, or to act less professionally. It might not be your right. But the fact that you are suggesting, it is your right. Everyone can suggest. Why not? So it's very nice. Look at the phrasing. Initially, to be honest, I wrote it, ask the consultant back. I say, no, I don't want to make it easy, make it a little bit difficult. Suggest. Suggest means you really know your limit. You really know your limit. Just suggest. Why not? So I will take it. It's just a suggestion. Tell the consultant you find this method of teaching unhelpful and ask him to stop. Stopping the flow of the word round, being confrontational, and he is the consultant. He knows better. If you have suggestion, it is your right to suggest, but later on. If you want to suggest here, you need to be nice. Yes, maybe you can suggest, but you need to be nice. So D is definitely incorrect. Yes, Dr.
I want to ask doctor in general, when there is in a question of something occurring during word round, and there's options, there's no mentioning after word round. I will assume this action will happen during word round.
Definitely.
Thank you very much.
Definitely. Here in C, I might go for it. Why? Because the exact example about side effect, you need to know and the patient needs to know. By the way, it is medically legally, you are medically bound to explain to the patient the side effects. And it's part of the PLAB, if you remember that. In the management domain, you need to explain the side effect because he needs to know and to make informed decision to say, yes, I accept it and I will take the risk. And you have to tell him it's rare. So now, C is nice, not just because suggest, because the example is about something very relevant to the patient and the patient needs to know it. So you need to deliver that message to the patient medically legally by suggesting. It's very nice. D is incorrect. E, defer the question by saying it is not relevant Okay, that means you are really missing the exact example. If we are talking about, for example, about uh, uh, we're talking about the natural history of the disease, or we are talking about the risk factor or something like that, that's more statistical. It might not be relevant to the patient, but we are talking about side effect for medication he will take in himself, so he needs to know about that. So E is, you are really terribly missing the point. F, make note, the question to look up after. This is complementary to B. So B and F, they work together. You are reassure him you will do it later, and then you will do it later. That's very nice. G, joke. This is unprofessional. You have forgotten. You have not forgotten. You don't know about it, so you are lying. H, ask the patient if they have experienced any side effect from their medication. It's very irrelevant. It's not the point. You cannot help and ask issue. You cannot help and you cannot solve no problem. It is not a problem. Why would you ask him if he had side effect? The consultant is there and no one mentioned anything about that. So you are just trying to deviate the discussion. Okay. So we are doing these two questions. So let me. The patient is readmitted with a second episode of diverticulitis in 6 months. They are frustrated and ask you why this keep happening and what they can do to prevent it. So basically, no one explained the nature and the prevention of diverticulitis for this patient. That's why I can tell from this example, because diverticulitis is a recurrent condition happening because of the diet and frequent constipation and things like that. So no one did that. And after getting diverticulosis, they might inflame, get diverticulitis. So admit that you don't know, but you will find out for them. It is not a fact. I don't know if I know or not. I don't know yet. You might know. Explain that high fiber diet can help prevent future episode. Again, this is a fact. Why high fiber diet? Because fiber diet means less constipation, and less constipation might prevent diverticulosis in the first place. Then, if no diverticulosis, there is no diverticulitis. So we know why people develop diverticulosis, but we don't know the exact reason for developing the diverticulitis from the diverticulosis. We don't know. If we know, we could prevent it. So that's why A might be correct, but leave it for now. Blame their previous team. This is very unprofessional and lying. I don't think any of us would think about this. Suggest they may need surgery and will be referred to a specialist. Is diverticulitis treated by surgery? No. If they have toxic megacolon or something or necrotic bowel, something like that, they might need surgery. But diverticulitis, we all know that it's just an antibiotic. So provide them with the patient information leaflets. It's very good because he lacks information. So he needs that information. That's very good. So I will go with B and E. They are very good. Tell the patient it's just bad luck. Nothing like this in medicine. We have nothing called bad luck. Either you have known the risk factor or you haven't. So you need to admit both ways. Nothing they can do. That's incorrect. Recommend they avoid nuts and seeds in their diet. So you might say this is good, but I say it is unfair because you will go for this like a high fiber. We all know high fiber diets. We all know that. Why? Preventing constipation in the first place. But nuts, it might not be fair. And I don't think in the real exam they will bring like 2 examples like this. So nuts is just like the MMR with autism. It's like an outdated data. Just one consultant found that out and thought there is a link, and it went viral. And a lot of people believed if I got the MMR, if my child got an MMR, he will have high possibility to acquire autism, and there was no link at all. So the same thing about the nuts. They are not linked to the diverticulitis at all. Arrange an urgent colonoscopy to rule out cancer. Again, try to learn. You cannot help no problem. You cannot solve no issue. Who spoke about cancer? Was there any sign or symptom about cancer or losing weight or unexplained hematochezia or anything? or melena? No. So why would you think about cancer? So you will go back to A. Admit that you don't know. You will find out for them. So B and E, they are good, but A is the only acceptable answer. Why? Because we have learned all of the other answers are very incorrect. So you have to develop this skill. You have to know why every other answer is not correct, so you can pick another one. Pick the last one. So you are the on-call junior doctor and are asked to review post-operative patient who is in pain. The nurse show shows you the drug chart. The patient is allergic to morphine. Morphine could cause a rash. So allergy is not all the same. They might it's ranging from anaphylactic shock to just simple rash. So and is currently prescribed regular paracetamol and ibuprofen. So he's post-op and in pain, and ibuprofen and paracetamol, they are not enough. What would you do? Prescribe different strong opioids such as oxycodone that might be enough for the pain, but what about the allergy? Because oxycodone is part of the narcotics, which is the morphine family. Is it safe to prescribe it? I will keep it aside now. Prescribe weak opioids like codeine. I'll keep it aside as well, because again, this is the morphine family. Prescribe antiemetic and in anticipation of opioid side effect. C is off point unless I'm going to prescribe opioid narcotics, so I will leave it on. I'm not sure if I'm prescribing that or not. If I'm prescribing this, I will add antiemetic, but not now. Let me just go through the options. Give the morphine anyway, as the rash, not a serious allergy. Yes, he had a rash with the morphine, but what if I gave him morphine now and he developed the rash? Is that something preferable? Do I need to give him a rash? Am I 100% that rash is the maximum manifestation he could go through? They mentioned the rash, yes, that means he's allergic and he will have a rash definitely, but can I cause my patient a rash? The answer is no, unless I have no other option and I'm really trading this for immediate patient safety. For example, this morphine will save his life for some reason and he will get a rash in expense, I might go for that, but it's not the case. So why will I give him free rash for no reason? No. Suggest non-pharmacological method like repositioning. Okay, this looks a good one. Ask the nurse that the patient usually takes, ask the nurse what the patient usually take at home for pain. Why? I don't think that's even relevant. So increase the dose of the ibuprofen. It might be a good option. Tell the nurse that the patient will have to wait for the pain to ease. So it's a really difficult one. I can exclude I can't exclude, just like first glance, I can exclude, maybe I can exclude D, I can exclude EH. So it's a really tough one. I just can't exclude D and H. Now you have to use your clinical sense. Some patient had very minor side effects or allergy side effect for a morphine. Can I use a morphine? The answer is not preferably. Why would you give him a rash? No. Can I use another medication from the same family? The answer would be clinically, yes. Why? If he has a very strong side effect like anaphylactic shock, you will never use the same medication and similar medication because there is cross-reactivity. So if he's reacting very badly to morphine, very badly, I cannot use oxycodone or codeine or whatever, because he's strongly allergic to morphine. He will be moderately or mildly allergic to the other medication. But if he is weakly allergic to morphine, clinically he would be free from allergy to other medication. You have to learn that. So I am free to give another narcotic or opioid other than morphine, because the initial allergic reaction to morphine itself was very minor, just a rash. I don't use morphine, but I can use other one. Even if there is a cross-reactivity, it would be very, very, very minor. because the initial one was minor anyway. So that's it. But if it was major, I cannot use the morphine and the similar medication because he might have a chance to have a moderate or even a severe reaction. So if it's already minor, that means the reaction to the other similar medication will be even more minor. Okay, so A will make sense and B will make sense. But what should I cannot go for A and B. I need to choose one. What do you think, A or B? Because we have learned the trick now. Yes, Dr. Sami.
Actually, according to the WHO ladder, so we have to start step by step. So, in my opinion, we have to start by weak opioid, codeine,
Very good.
according to the ladder.
Very good. Very good. What do you think, Dr. Sandrilla?
Same, doctor. I think it's codeine, but in answer key, it's oxycodone.
So what do you think?
Maybe because he's post-op, we afraid
Yes.
from constipation, so we give oxycodone.
Okay, okay. Very good. Very good. Very good. I will take this. Yes, Dr. Faisal, what do you think?
Yes, I think because the patient is post-op, so we should start with the strong opioid. And then similarly, I think for the cancer, metastatic cancer patients, we go for the, strong opioid. So
Okay.
yeah, I'll start with A actually. I'll give A.
Okay, okay. Very good. Very good. Thank you so much. Yes, Dr. Mihad?
So, I have a surgical background, so
Okay.
it's either two ways. You can start with a strong opioid, or the other way with, they said the ladder, the pain ladder. The pain ladder says that you have to give non-steroidal plus the weak opioid. It's not just the weak opioid alone. So the problem is he's post-operative, so you are afraid of the stress ulcers like this. So, and you're also afraid of the renal function because he's also post-op. So that's why, if you go for B, you have to go with G, but G is bad. So that's why you will cancel B and G. This is for
Okay, very good clinical insight. I will make it even easier for you. Look at this. The drug chart. Allergic to morphine. What do you think about this? So this is not generic information. He's showing you the chart now, and the chart is telling he's allergic to morphine. What do you think about this? Yes, Dr. Sami?
So now you mentioned the point exactly. So from the chart, we can understand that he is now on the level of strong opioid.
Yeah, because we are talking about the level of morphine now. We have already beyond that level. So they made it easy for you. They've tried morphine. Someone mentioned morphine, but morphine is allergic. He's allergic to. So we are talking about a pain that needs a morphine. But unfortunately, morphine, he's allergic to morphine. So, and he's post-op. That's not enough. I would say it's a very strong hint, but it's not enough to start very strong on it. But we are talking about morphine level. That means definitely codeine would not be enough. And he is in pain now. Is he in maximum dose of paracetamol and ibuprofen? I don't know, but I can't presume. I'm not sure. However, he is at the level of the morphine. At the level of the morphine, it's definitely oxycodone, not the codeine. So I need strong opioid to alternate, to replace the morphine. So oxycodone is a good option. If I'm going for A, I will definitely be going for C, because it is a strong opioid. It might cause very famous, popular, common side effect, which is GI upset, nausea, and vomiting. So I need to give him that. So A, because it's good, strong, and the allergic reaction was minor, so I can go for similar medication, not the same medication. A, then C. So I need to find out another answer. Why? Because I meant to pick three, A and C. B is not good because I chose A, definitely. And C is not an option because of the allergic reaction, and I went for A anyway. So E is not an option. Someone is post-op and severe pain needed morphine and oxycodone. How can I say repositioning? That makes no sense. It's post-op pain. Post-op pain, you need to. It will be A and C. E makes no sense. Then I have F, G, and H. If I'm giving oxycodone, could I increase the ibuprofen? I might do that, but why? because oxycodone must be enough itself, and I'm increasing the risk for something else. But in F, why it's important? Because I need to know why he is taking at home. That will help me to tailor and understand his pain tolerance. He's in pain now. He's on ibuprofen and paracetamol. If I knew he's already on codeine, that means even codeine is not helping. No point for repeating myself. I need to go to something stronger. So just knowing the information is very important. So the action is oxycodone and antiemetic. They are together, and it is part of the pain assessment to know part of the history. You have to know what he's taking at home. This is part of pain management. You have to know because of the tolerance and threshold. Yes, Dr. Mia?
Clinical wise, repositioning is correct. That's why I'm really confused about this. Between E and F, I will go for E. Repositioning we do that. We tell them, that's why we are telling them to move on early and not only for the like the risk of the like clots and emboli. Like this repositioning is very good for pain management. So I'm
Okay.
very confused.
So you have to pick just 3 options. Just 3. Would you go for oxycodone and antiemetic, which is one thing? If you are prescribing oxycodone, you are now adding new risk of GI upset and GI laziness. You have to treat that. So if you are going for oxycodone, you are going for antiemetic, no other way. So are you going for this together with history of pain, his pain tolerance and pain management, or you are going with both of them and repositioning? You have to choose just one answer. What do you think?
Both of them and repositioning. I don't understand why F is correct.
Oh, okay, fair enough, no problem. Do we all agree about that? Or what do you think? Yes, Dr. Faisal.
Yes, I'm actually of the same point. But while we are discussing, it's making some sense now regarding F. But I took E, of course, because in a combination, I thought I'm repositioning, I'm giving the opioid and medication. But then asking about, as you said, that what he takes at home might change my further management. But as a combination, I went for E actually. So it's a bit of a tie for me as well, E and F.
Oh, okay, we'll answer that, don't worry. Yes, Dr. Samir. It's a really tricky question. Yes, Dr. Samir.
To be honest, I strictly follow the NICE guidelines in this question. So I didn't prescribe for constipation in advance. So why I assume maybe he will not have. Okay.
No, it doesn't work this way. If you are adding a medication that might commonly cause a side effect, you have to prescribe that. That's why when we are prescribing, for example, alendronate or whatever, or steroid, we are giving vitamin D. He might not have osteoporosis or osteopenia, but you need to, because you increase the risk iatrogenically. The risk was, for example, 1%. Now, by giving this, you made it 15%, 20%. The risk is increased. The risk is not 100%. There is no risk 100%. 100%, that means he will have it. So, in medicine, we are increasing the risk iatrogenically. We did that. We need to make a plan for that. You have no other option. But
sorry, and that's why I didn't choose the constipation. I chose E because it's very good option in many things, in pain management and physiotherapy and prevention of DVT and many things. So I chose E.
Okay, so why E is a very good option, but number 4 here, let's say. Now, you have a patient who is meant to have morphine, but he's allergic and he's post-op, and he is in pain now, and he is on paracetamol and ibuprofen. You have the luxury to choose 3, not 4. What will you start with? For me, clinically, I will start with F. He told me part of the history that he is allergic to morphine. That means he needs a strong painkiller at a morphine level, which is oxycodone, but I'm not sure yet. I'm yet to prescribe that. First of all, before going to which painkiller that I'm going to prescribe, as a pain management, step number 1 in pain management in history, to acquire about his tolerance, which is not, which is clearly he's not tolerating the pain now. He's still on paracetamol and ibuprofen, and asking about his regular analgesics. Why? Because he might be regularly on paracetamol and ibuprofen for ages. That's why they are not touching him. Number one. So I'm not going for G. That's not going to help. Not just that, it is a very essential fundamental piece of information for pain management. This is now like clinical scenario. To know his long-term painkiller or analgesia. Why? Because I would like to reassess the risk of analgesia-induced nephropathy, for example. That's why I'm not going for any narcotics that is harming the kidney, or any NSAID that's harming the kidney. I might stop the paracetamol and ibuprofen anyway. So asking information about the pain, they are essential to information. His tolerance, that you will tell him, how do you tolerate the pain now? How do you feel the pain? They are telling you he's in pain now. Number two, his regular painkiller. That's giving you a good hint about what to do and what to exclude. So F is the step number one. You have to start with F, what he's usually taking. It's part of the pain management of pain history. So now you have step number two. Either you are repositioning him and giving him oxycodone, which reposition itself would not be enough. Definitely, he's at the level of, but it's very good additive. Very good additive. I agree. So, or giving him the oxycodone plus the repositioning without giving the antiemetic. Pain-wise, now the only thing will touch the pain exactly the strong painkiller at the morphine level, which is oxycodone. Does that mean repositioning is not going to help? No, will add a value. Yes. So as a painkiller, repositioning itself is not enough. Maybe with oxycodone. Okay, so I'm going to prescribe oxycodone, not a codeine, because codeine is far less than morphine. Okay, I have a fact, a hint, I need to utilize that. If I'm going to prescribe oxycodone, this is my perception. Which is better? To ask him for repositioning, which is something they, as a nurse, they need to do that anyway. This is not like a doctor job. It's good to suggest, I understand that. But I might be adding something very little because they might be doing that, and asking for repositioning, the repositioning is indicated for the pain and for other things like bed sore and things like that, which is primarily a nurse job and it meant to be part of the post-op instruction, which is, I'm not the surgeon, I'm just here to manage the pain. So my task, is it better for me to fully address the pain or to add something might address, will help with the pain, and there is a high possibility that task might be already part of the post-op, which is the surgeon job, and the nursing instruction for any post-op patient. So you need to sacrifice something for something. So as a doctor, it is not part of the nurse job to wait and recognize the home painkiller practice of the patient. This is not part of their job. This is part of the history. I need to know that. And it is not part of their job to know about the oxycodone and the rest. This is my job. So I thought about A and C. This is primarily a doctor job. If you are prescribing something, you have to completely prescribe everything. Better than suggesting something which is nice, helpful, but as an additive, and it meant to be there already by the surgeon, which is consultant, which is who is consultant, and we believe the consultant will do the best care, will represent the GMC without me needing to prompt him until proven otherwise. And it is the nurse job and the nurse in charge job to already reposition the patient. So addition wise, I'm adding more by adding antiemetic. This is primarily a F2 job, and adding very less by re-emphasizing their own job. If I had a hint that the patient had a bed sore or very new nurse, or they had some problems, I might go by re-emphasizing that in E. But I'm stuck between 4 options. I need to utilize every single information, every single thing. Again, scoring 8 in this question is, for me, fair because it's a really tricky question. But you need a lot of clinical insight and a lot of assumptions, appropriate assumptions, that the consultant will do this. This is his job. It's not my primary job. to emphasize the consultant instruction unless I got a hint. And it's not my primary job to emphasize the nurse job, because they need to do that with every single post-op patient, not just this one, for so many reasons, as we know. So for me, I will go for the option that will add a new value from F2 perspectives, which is asking about history and adding things medically. They cannot add that as a nurses. So that's why I would never go for E in this scenario. Unless they are giving me extra hints, like they are new, they need support in their own job. Like the two examples that we had, it was a new nurse. She cannot go further. She cannot help the patient with a complex dressing, something like that. But between me adding my only job or helping her job, I will do my job. Because I can safely presume the consultant already has written that post already. That's the only reason. It's really tough, to be honest. And for such questions, I think it's fair for them to give, if you are choosing E, to be in this specific question, to give you maybe 2 marks out of 4. They should not give you 0, to be honest. It's really tough. And you need to sort all of that out in less than 2 minutes. It's really tough. You will have questions like that in the real exam. However, I will make it very simple. Now, you have 4 options. You need to exclude one. Which is less related to F2, I would say taking history is your job. The nurse cannot do that. Repositioning the patient is her job and the consultant task. So I might leave that later on. That's all. I hope that makes sense for you. Yes,
Can we help the last question 46?
was it added in the list or no? Yes, it
Yeah,
was.
was added.
Okay, no problem. So this is the last question. So you are asked to certify a patient who has died. Okay, so there is something called death certificate. It's a legal document. You have to fill it down after you have seen the patient, you knew about the patient, and you knew the cause of the death, and you sign. And you will be paid for that, by the way. So it's a legal document. On review, you did not know the patient, problem starts. And the notes are sparse. So you cannot, even if you don't know the patient, you might gather enough information to sign it from the note, but that's not even applicable here. You cannot find documented cause of death. So basically, you cannot go further. You cannot help this. You cannot, because if you are doing so, like you are fabricating, and this is a legal document. A, right cardiac arrest. This is, I don't think any of us will go for this. Come on, because you don't know. So B, contact the patient's usual team or the consultant to establish the cause of death, which is very good. This is alternative. Either you know the patient, you read the note, or you ask someone who knows. So B is very good alternative. C, refuse to complete. I will go for this, definitely. If no better options or just B correct answer, I will go with C, definitely. Like the one who asked you for a body signatory. We ask you to sign just friendly. Either you have the proper way of assessment or you say no. So I would go with C as well. Perform brief examination on the body for any obvious sign. Is that enough to sign death certificate? The answer is no. Is it helpful to do? Yes, because you might have something very clear. You might be very, very lucky and have something very clear telling you this is the patient. For example, stop wound, something like that, because you don't know the patient. So brief examination most of the time would not be helpful, but just doing the brief examination is not going to harm, not going to delay anything. It will give you a chance that you might find something. So you are doing something. The safe thing to go for B, but meanwhile you are performing brief examination of the body is not harmful. Is there something legal to do it? Yes. Why? Because you are a doctor. You are not examining that after they burying the body or after they left the hospital. He is still under your care. So can you do a brief examination? Yes. Is that enough? No. But you are not taking this unilaterally. You are asking in B. So if it was ranking, this would be number 4 or 3, to be honest, because itself it's less reliable. But now I'm not taking it solo, unilaterally. I have other answers. So in combination, it makes sense. This is the big difference between ranking and best of 8. If it's ranking, I take it by itself is not reliable. I cannot do brief. That's not even enough. But while asking the appropriate team and consultant, why not? It will add some value. It might not add, but it's not causing any harm. So by itself is not enough. But with other appropriate things, it shows that you are keen, proactive, and still safe because you are not taking it alone. Alone is not enough, but with other things. So why not? So I will go with it with B. So D, I will go with it with B. So basically, I would say B, C, D. Either you go with B and D together, or you refuse with C. E, speak to the nurse staff who knew the patient to understand their medical history. It is good but bad. Why? Good to speak to the nurse, but not for the medical history. Maybe for the nursery history, bed sores, whatever, but not for the medical history. That is not even enough. And you are burdening them for something that is not his job, their job. So you're asking doctor, yes. And you cannot go for B and E. B, asking the consultant and the doctor, and then asking the nurses. So if they tell you, ask the nurse for their advice or how to proceed or what do they think, it might be nice, but not for the medical history. Medical history from the notes or from doctors. Document cause of death unknown on the certificate. Now, I will not go for this unless I didn't know anything. Is it legal to document that? Yes, because we don't know the cause of death all the time. And it's very common practice, unknown cause of death, yes. Refer the death to the coroner. This is not your decision. It should be either by the consultant or the family, or if there was like any concern around the death that it was not something explainable and there was some maybe criminal issues behind that, something like that, any issues, it should be by the consultant or the coroner or the family or the coroner himself. So there is no such indication in the stem. Okay. H, ask the family what they think their relative died for. That makes no sense. That's against the sympathy and empathy and confidentiality. You cannot do that. The patient has the right of confidentiality even after he died. So I have either B or C or D or E, but we've learned why E is not correct because they specify medical history, and maybe F. G should be by the consultant or the coroner, or if we are querying the cause of this, we are not happy, something is missing here, and we suggest that by the consultant. You cannot refer the patient himself, or if the consultant or the relative or the coroner himself. So even if you are querying, you are not sure, you don't know the patient anyway, you don't have enough information to say, oh, there is something dodgy here, I need to understand why. You don't have that information. Even if though you will discuss with the consultant, you cannot refer him yourself. You cannot do that. You are not eligible to do that. So B, C, D, and F. You have to exclude one. So B is definitely there. And C, D, and F, you have to exclude one. Either to refuse until the notes are complete. For me, I will exclude C. You can refuse. Why? Because you don't know information, but not because the notes are not complete. Because notes are not the only way you could complete the death certificate. You are saying the only way is the note. If the note is there, I can do it. If the note is there, I cannot do it. No. Either you yourself know the patient or the note, or the consultant or the team. If someone told you this, you can do it. Like discharge summary. You need to gather the information. You make it informed and professional. If you gather the information from the professional routes, like the notes, or yourself knowing the patient, or the consultant or the team, that's it. So that's why I exclude C, by reading the full sentence. Refuse till the notes are complete. Does that mean the patient has no right to be buried and have a death certificate unless we have the note? What if we didn't have the note? Someone just destroyed the note. What would you do? We'll keep the patient there? No, it's not even humane. So you cannot do that. So C, because it's incorrectly built, I will go for B, D, and F. F, to be honest, is not the best practice. Why? Because you are contacting the team. Why would you presume unknown? It's unknown for you, yes, but why would you presume something like that? But C is less professional and illegal. So that's why I go for F. In the real exam, believe me, F would not be the best answer because they will give you a better option. But I made it difficult to test. Do you know why the other options are bad or not. A is a complete lie. C is very illegal. You cannot condition completing the certificate to the note. No, this is illegal. If you have any other alternative professional, you go for it. So E is very unreliable because you are asking for a medical history from the nursing staff, and G is not your right. You cannot do that. H is against confidentiality. However, F is not the bit, but it is not incorrect because it is unknown for you. Yes, Dr. Cinderella.
Actually, doctor, the key answer is B, D, E. When you give us the key answer, it was B, D, E.
To be honest, speaking to the nurse about the medical history is not bad, but because we specified medical history, it might not be the best. So documenting the cause of the death as certificate is unknown. I know it is premature. Why premature? Because you are not sure if it's unknown or not, and you are going to talk to the consultants. So I was really between keeping E or F. However, speaking to the nursing staff, oh, I missed this, to be honest. So speaking to the nursing staff, if you are talking to them regarding their job, that's it. If you are talking to them about the medical history, it's not fair for them because they will not know. You need to speak to the doctor. But this exam is very situational. Now you are talking about the nursing staff, who knew the patient. What does that mean? They took care of the patient. I really changed my mind now. Took care of the patient. They knew the consultant and the team who were treating the patient, and they were in contact with the medical team, because the medical team, if they, for example, say, okay, this is the plan of management, they will convey that to the nurses. So this condition is really important. If you are talking generally, talk with the nursing staff about the medical history, that's unreliable. But who knew the patient? I change my mind now. I will keep E. F is the less harmful, but it's not correct because you don't know. But if you are talking about the nursing staff who knew the patient, I will go for it. Yes, thank you for this. So I'll go for B definitely, and D because there is no harm by itself. It's not reliable, but with other reliable measure, it's adding no harm and it might help. So in ranking, I'm not keeping D at all, but 3 I will add D. Why not? So B, D, and E. Yes, I agree. Thank you so much. Yes, Dr. Samin.
Yes, just general info to give us a better understanding. So in UK, is it possible to sign a death certificate before completing the notes?
No, but the notes are sparse. You don't know where the note is, and for some reason, this is less than ideal thing happened, and the patient now died. So can you condition that no death certificate till we complete the note? The answer is no. Why? Because death certificate needs appropriate amount of information to fill it. This information could be gained from the note. I agree. Could be from the team themselves, yes, and from yourselves. So you cannot say just the note. What if the consultant himself came and he wanted you to write this and he's giving you the history? Would you say no, I need the note? You cannot say that. That's what I meant by C.
Yeah, okay, but sorry, this is just my understanding. Maybe I'm wrong. So option C, for me, I'm doing something illegal.
Definitely.
To be honest, this is my understanding. C, I do something illegal.
Definitely. You cannot say I'm not writing the certificate till we finish the note. No. What if the one who wrote the note say no, I'm not writing that? I'm being unprofessional and I'm not completing the note. What would you do? Would you still suspend the patient here?
I don't have exact idea.
The answer is no. You have no right to do that.
I'm
The
not.
only thing for you.
Yeah.
So you have two problems. The incomplete note, which is separate, independent problem. You need to sort that out, but not now. And you have the death certificate. This certificate is about the dignity of the patient who died. You cannot Link them together. Unless someone completed the note, I'm not even treating that patient. Who are you to say that? No. This patient needs to be taken care of and needs to be the paperwork needs to be completed regardless you completed the note or not. This is your own problem, your own department problem. The patient should never suffer any complication because your incompetence as a department. Nothing to do with that. It's just like saying, okay, this patient would not be discharged or not be given the medication unless someone doing history. You cannot do that. Yes, not doing history is a bad thing, but this is your own problem. You cannot subject the patient to harm because of that.
Yeah, it looks like as a threat. If you don't do this, I don't do it. Like when we have many examples for the patient, we don't prescribe this if you don't stop smoking.
Exactly.
For example,
That's even worse. Here, the example is even worse. Yes,
thank you.
because you are blaming dead body for someone else's mistake. It's not even disability.
Okay, thank you.
So again, I'm sorry for that. This example is really situational. Just to let you know that I don't memorize the answers and I don't learn them and memorize them. You have to follow the same. Now, for example, if they made general statement, ask the nursing staff about the medical history, it does not make sense. It is not reliable. But ask the nurses who knew the patient, that makes a lot of sense now because they were in contact. Now I really go for E, definitely, blindly. E, B, and D. F is not a good option, but it's safe to say unknown because you don't know. It does not make sense because you are asking in B, asking the consultant, you will know. But if you have just two options, asking a generic staff about the medical history, that will make no sense. But keeping in the document that it's not unknown, it's unknown for you, which is less appropriate because you might be able to know by asking someone who knows. Why would you jump to conclusion? And by the way, you might ask them and they might tell you unknown. They might. That's why I kept F better. But if we have that condition who knew the patient, that really changing the game, I'll go for E. So you will never memorize, rely on your short-term memory. You have to understand the stem and that's why I'm telling you, even if I missed one hint, I will really lose one answer because it's just like that. Hints, concepts equals answer. So if you lose one, you will lose. So because I was rushing, if you rushed through the options, you will lose 1-2 words and you will lose the answer. One word will change the mind. Really, 2 words will change the mind. Just who knew the patient, that change everything. Okay. I hope you are feeling more confident now. Yes, Dr. Sandra.